हम निकलेंगे बस निकल।
अच्छा
मैम
निकलेंगे
कंचन मैम,
मतलब।
हाँ स्टार्ट करें मैम, स्टार्ट करें ना?
श्योर श्योर श्योर।
Yes.
मैम we are
Good
recording
evening, Usha
and
ma'am.
the session is live on YouTube.
Hi, Shaili.
हेलो
हेलो मैम, नमस्कार।
हेलो
Hello.
तो डॉक्टर
Uh,
सीमा आप।
Kanchan ma'am, should we start?
या
हेलो हेलो
हेलो
Very good evening to all respected doctors. This is Feroz Khan from Team Walter Bushnell. I welcome you all to this live webinar organized by Kanpur Obs and Gynae Society and other Foxy societies on the topic female breast issues. We look forward to a great dissemination of scientific knowledge and experience sharing. With this, I would take this privilege to hand over this virtual dais to Dr. Seema Dwivedi ma'am, who is the professor GSVM Medical College Kanpur, to moderate the session ahead. Over to you, respected Seema Dwivedi ma'am.
Feroz. Good evening, everyone. As I welcome you all in this vibrant, versatile webinar on breast issues, I welcome the dignified dignitaries and august audience. Going along with the tradition of lamp lightning, I call upon the Almighty for his august presence. I call upon Shiva, O Shiva, to be the lamp that pervades all existence, a lamp that removes all darkness, and a lamp that can achieve everything. I hand over the webinar proceedings to Dr. Kanchan Sharma, the dedicated, diligent, and dynamic secretary of COGS for Lamp Lightning and Welcome Address. Over to you, ma'am.
Thank you, Dr. Seema, for a wonderful opening. At the outset, I, Dr. Kanchan Sharma, Secretary COGS, along with my President, Dr. Usha Goenka, welcome all the dignitaries from the national platform, guest faculties, and delegates to this academic bonanza on breast issues. Breast is an integral part of gynecological examination. It is an important reproductive organ and that undergoes changes during pregnancy, lactation, and late reproductive years. So we gynecologists should be well versed with all the breast issues. In today's webinar, we are discussing about the optimizing breast feeding, its myths and misconceptions, and panel about the nipple discharges. Practice is an essential factor for mind management in all the fields of human endeavors. And practice is the key that opens the door to mystery and excellence. Now we start our session with blessings of that Almighty God. So please show the video of lamp lightning. I invite all of you.
Gurutvam kalyanam arogyam dhanasampadah shubham kurutvam kalyanam arogyam dhanasampadah shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः.
Thank God, thank that divine power. His divine power has granted to us all the things that pertain to life and the godliness. Now I am going to present the CV of a great national leader. Please show the CV of Dr. Meera Agnihotri. He's a teacher of teachers, very humble, ever smiling, always blessing. My guru. She is a retired HOD of GSVM Medical College, Dr. Professor Meera Agnihotri, ma'am. You can please show the CV of ma'am. She is Professor Dr. Meera Agnihotri. She is head Obstetrics and Gynae, GSM Medical College, Kanpur, retired. She is a chairman of Ethics and Research, State Medical College. She is president of WWW Foundation. She is advisor of Women Health Cell, Ministry of Health, Government of India. Shapath 1000 for the National Health Program, launched on 24 January in 2021. She got ICOG Ratna Samman and Golden Plaque 23rd AICOG 2020 Foxy. She got Impact Award for Women Empowerment and COVID Service by the Cabinet Ministry, July 2021. She organized International WWCon inaugurated by President of India and Union Health Minister. She successfully led collaborative group of 13 organizations supporting Foxy position statement to Ministry of Health, Government of India for COVID vaccination to lactating and the pregnant women. She got many internationally she represented India, Foxy National Chairperson AIDS in 19th FIGO at the Montreal, Canada. She was visiting consultant at Baylor College of Medicine Department of Gynecology in Texas, USA. She had many
Kanchan, I can go ahead.
contributions. Yeah,
Kanchan, thank
ma'am.
you. It's okay. I can go ahead now.
Yeah, ma'am. Now we need a few words of blessings from you. Thank you for joining us, ma'am. Please bless us.
I'm really very much honored to be a part of this wonderful webinar organized by Secretary Koch Society and the President Koch Society, Dr. Kanchan Sharma and Dr. Usha Goenka. And I'm a proud teacher of them. Kanchan is a very vibrant, active, ever smiling secretary. And she, along with Usha, makes a duo, a deadly duo which can do anything. So that is a wonderful meeting. Now, Kanchan and Usha, I'm really grateful to share the dais with dignitaries like Dr. Madhuri Patel, none other than Secretary General of Foxy, my very good friend, a lovely personality, always at a phone call distance, and you can talk on any length of the time for any subject whenever you are in trouble, whether you are organizing an international meeting or a national meeting or whatever it is. Then another dignitary, Kavita Bapat, who is going to organize AICOG, for which everybody is waiting. I believe I'll also be present over there, and everybody really wanting to attend it. Sneha Bhuyar, Foxy chairperson for the breast committee. I have done batting in her chairmanship with Usha ji, and I don't know whether I won or lost, but I've made many runs. I could get or I could not get, she will tell you. She has run the breast committee very nicely, making me a cricket player of the breast committee. And the scientific agenda taken today is really very, very important. That is about the breast. Friends, when I was a demonstrator and lecturer, जनरल सर्जन्स और ऑब्स्टेट्रिशियन और गायनेकोलॉजिस्ट पे बहुत टग ऑफ वॉर होती थी. ब्रेस्ट इज अ पार्ट ऑफ गायनेकोलॉजी, ब्रेस्ट इज अ पार्ट ऑफ सर्जन, ब्रेस्ट इज दैट एंड ultimately it was being decided breast is definitely a part of obstetrician and gynecologist. Why? Our case presentation, when you come and do it, whether it is an undergraduate examination or a postgraduate examination, if you forget the examination of the breast, I can tell you that you will be losing marks. I saw Professor Engineer who was a co-examiner once upon a time, and a case was presented, most likely purpurium or whatever it is. The boy could not present the examination of the breast. She said, why didn't you examine breast? He was a little nervous, said, Madam, breast हमको नहीं दिखाते, like whatever he told, and he was failed. I tell you, he was asked to come again. So breast is a very important thing. It is not only reproductive or this and that. Right from womb to tomb, I must say, we must be fully prepared with the management. And today, most of the part will be discussed. And the plans of academic sessions are very, very good. First part will be discussed by Dr. Kanchan Sharma, optimizing breastfeeding, a very important subject. And second important topic, myths and difficult conditions in breastfeeding by Dr. Kiran Pandey. And both Kanchan and Kiran, starting with K, addressing to Kavita, I can tell they are they are very bright pearls of Kanpur Obstetrics and Gynec Society. And while I'm talking about their topic, I just very humbly request all the persons, our lovely, beautiful secretaries, presidents, and any audience present over there to please shower your blessings for both of them, because Kanchan, our Secretary General, is contesting for the breast committee, and I believe Sneha will be supporting her right and left, and Kiran will be contesting for medical education committee. And I request all of you to please shower your blessings. And for requesting it, I must start from the top. And top means just tell who is at the top right now.
Dr. Madhuri.
Madhuri is not responding. That is why I am telling. Madhuri, are you here? You are audible? I am audible to you.
आपका म्यूट अनम्यूट कर लीजिए मैम.
Madhuri is not.
Connection problem. That's why, I'm on my mobile now.
Okay. So Madhuri, kindly take care of 2Ks, Kanchan and Kiran. The reins are in your hand, I believe. I will be there at your back. So the scientific program is very, very good. And the chairperson present over there, Dr. Aarti Luthra, who is president from Dehradun, convey my regards to Chaturvedi. Dr. Preeti Sharma, who is president of the Jaipur, and Dr. Anupma Rani, president from Rudrapur. And for the second session, with Dr. Kiran Pandey as a speaker, Sujata Sharma, president Amritsar Society, Dr. Sandhya Sharma, president Haridwar, and Dr. Shahnaz, president from Srinagar. I don't know if she is able to join it or not. The panel discussion will be very, very good. I know that nipple discharge is one of the most important things we must know. To start with, when you are on round, sometimes after the delivery of a girl, and in the ward, after taking round, when you are moving forward, the attendants come and tell, Madam, there is some discharge from the newborns, new baby's breast, and they are very worried sometimes. I think most of you must have faced this problem. So we must know and we must tell how to tackle it. It is very physiological, need not to, because they think that the baby is born with some tumor or cancer and so on and so forth. So discharges begin just after birth, and we must be able to classify, satisfy, and treat them accordingly so that the attendants are not worried. The moderators, Dr. Ishu and Kanchan Sharma, and learned expert of the Usha Goenka, and Seema Dwivedi will be master of ceremonies. Alka Sethi, Radhika, Taru, Pavan, Nikhat, and Shaili Agarwal, all learned panelists. They will be dealing with the discharges. Friends, it's going to be a wonderful session. And I believe the back home messages will be very, very clear. All the presidents and secretaries present over there. I can see Preeti Sharma also. Did I mention it or not? Preeti is there. Aarti Luthra I can see, but some of the faces are missing. Preeti, I can see you. Dr. Radhika is, I can see. Taru is visible right now. Sneha. Now, Madhuri, you are stable on the this thing or not?
Please unmute yourself.
Yes, yes, madam. Yeah.
Right. So, with these words, I can tell you, friends, it is going to be a wonderful session, and discharges will be discussed in detail, so that there is a clear back home messages between the physiological discharges, benign discharges, and malignant discharges, because that is the key of success for the treatment. I once again congratulate Kanchan and Usha, our president and secretary, for organizing this wonderful webinar, where I can see right from Madhuri, Kavita, and everybody who was here. I don't want to leave the dais, but I have to. So with these words, I extend my love, my blessings, everything for the success of this wonderful meeting. And you must come home with the good back home messages, because both the speakers and the panelists, they are really wonderful. I have attended their meetings, lectures, and sermons many times. So I don't know the way they will be presenting. It will be very beneficial for all of you. Thank you once again for making me a part of this meeting. And I really want to congratulate all of you and wish you grand success for this meeting. Thank you, Kanchan, once again for calling me. और आप लोग अपनी सोसाइटीज के लिए कस के मेहनत करिए, और इतने बड़े बड़े लोग आपके साथ हैं. माधुरी इज देयर, स्नेहा इज देयर, ये लोग तो मजे हुए खिलाड़ी हैं. ऊपर से वेयर इज कविता, शी हैज डिसअपीयर्ड आई बिलीव, so they will be supporting you. Thank you very much, all the presidents, all the secretaries. Please take care of these two bright, brilliant candidates. Make them a part of Foxy. Thank you very much.
Thank you.
थैंक यू
ma'am,
वेरी
for
मच. आपने हम
blessing
लोग को
us.
इतनी ब्लेसिंग्स दी और हमारे लिए इतना कंचन और वो हम लोग
आशीर्वाद
आपके
दिया जी.
ग्रेटफुल है.
थैंक यू मैम. वी आर मतलब वर्ड्स तो कम पड़ जाते हैं. मैम, यू आर आवर गुरु एंड ऑलवेज ब्लेसिंग अस. योगेन जी, देयर इज अ बुके फॉर मैम. प्लीज शो दैट बुके, virtual bouquet.
Okay.
And then I'll request ma'am to introduce our Dr. Madhuri Patel, our Secretary General. First, show the bouquet of ma'am, the virtual bouquet, please. Yeah, ma'am, this bouquet is for
Thank
you.
you very much. Thank you very much.
Thanks for
Lovely
blessing us.
roses. I want to see everybody pink all over. All through, my blessings are always with you.
Thank you, ma'am. I request you to please introduce our other chief guest, Dr. Madhuri Patel, ma'am. CV of Dr. Madhuri Patel.
Yes. Dr. Madhuri, you are here? Dr.
Yes.
Madhuri Patel? Madhuri, am I audible to you?
Ma'am, please unmute yourself.
Yes,
Madam. Yes.
Madhuri, am I audible to you or not? She's not
Can you hear me,
connected, I
madam?
believe. Madhuri is not connected, I believe.
But can you hear me? Can you hear me?
Ji, 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 ji.
Yes, Madhuri, am I audible to you?
I can hear you.
Yes.
She is connected.
थोड़ा सा
we can see her, Kanchan, actually, but I think her internet is poor. It's weak.
I'll join from my mobile.
She's joining from her mobile.
Okay, okay, Madhuri, I am waiting.
Yes, madam.
Am I audible right now or not, Madhuri?
She's joining from her mobile, I think.
मैडम आप ऑडिबल हैं?
No, no, I am audible, but
उनको, हाँ,
Madhuri is not
madhuri.
audible.
डॉक्टर माधुरी का आया तो था. यस यस.
नहीं नहीं, she is not.
She has joined, ma'am. थोड़ा सा
मैम,
नेटवर्क इश्यू.
उनके शायद नेटवर्क इश्यू हो रहा है उनका ना. नेटवर्क बाबा आ रहा है जा रहा है उनका, ऐसा लग रहा है.
नेटवर्क इश्यू. आप इंट्रोड्यूस करिए.
I joined.
She has
Okay,
joined.
okay, okay, Madhuri. So it's indeed an honor to share the dais with Dr. Madhuri Patel, a very good friend of mine, always right and left whenever she is needed for any international or national conference or any Foxy information. She's very pleasant personality. She was joint secretary of the Foxy in 2009. Presently, she is Secretary General of the Foxy, and it is one of the very important designations as regards our Foxy. She is former committee member, FIGO, in preterm birth and preterm birth. Myself and Madhuri have conducted a panel last time in Delhi. Associate Editor, Journal of Obstetrics and Gynecology, India. She is Honorary Clinical Associate, Wadia Hospital, Parel, Mumbai. She is Honorary Consultant, Police Hospital, Mumbai. She is Visiting Consultant, St. Elizabeth Hospital, Mumbai. Former Professor HOD, Obstetrics and Gynae, PGI, MSR, Mumbai. She is former Associate Professor of GMC, Mumbai, India. She was awarded MOGS, Shailaja and Mr. Narayan Pandit Award for the year 2020. Delivered guest lecture at national and international levels, keynote addresses at many places. She has more than a number of publications which I know myself. She is Associate Editor of the Foxy award-winning book, Gynecological Cancer 2007. So I know how these are the few things which I could read, but I know that there are many, many more feathers in her crown. If I keep on reading and narrating, I will take away the scientific time. So I will not do that. So with these words, I invite Dr. Madhuri Patel to extend few words to this Congress for success. Madhuri Patel, the dais is yours. Madhuri, are you here?
Yeah, I'm here. Madam, can you hear me?
Yes, 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 it's okay.
Yes. Thank you, madam. I will consider Madam Meera Agnihotri as my elder sister. Thank you very much for your kind and generous words. I'm really touched by your words, and I'm there at your anytime, madam. Anything is required, I'm there.
I know.
And of course, we are good friends, but the relation between us is like a sister. So I
Right.
really appreciate from my side, madam, for giving me such a good introduction, warm and generous introduction. Respected our chief guest, Madam Meera Agnihotri, then our guest of honor, Dr. Kavita Bapat, then Dr. Sneha Bhuye, Chairperson Breast Committee, Dr. Usha Goenka, President Kanpur OBGY Society, Dr. Aarti Luthra, President Dehradun OBGYS, Dr. Preeti Sharma, President Jaipur OBGYS, Dr. Anupama Ravi Putela, President Rudrapur OBGYS, Dr. Shudyata Sharma, President Amritsar OBGYS, Dr. Sandhya Sharma, President Haridwar OBGYS, Dr. Shehnaz, President Srinagar OBGYS, then Dr. Kanchan Sharma, Dr. Alka Shetty, Dr. Radhika Raturi, Dr. Tanu Chaya Bansal, Dr. Pawanpreet, Dr. Nikhat, Dr. Shaili, Professor Dr. Kiran Pandey, Dr. Reshu Agarwal, and our Master of Ceremony, Dr. Seema Trivedi, and all my dear friends. Very good evening to all of you.
Hello.
At the outset, I would like to thank Kanpur OBGY Society and other society for honoring me as guest of honor. I would, as a Foxy Secretary General, as Madam Agnihotri has rightly mentioned, that I had lots of responsibility, but I would like to take an opportunity to say that the Foxy is the most vibrant, prestigious, and one of the largest OBGY organization in the world, with 263 member bodies and 38,000 plus committed members to women's health. And of course, our primary mission is reduction in maternal mortality rate, as well as overall health of the women. And I would like to mention that Foxy has two academic wings, that is ICOG and JOGI. ICOG carries out the college activities along with the training and certification courses. And we have fellowship as well as the membership. The journal, we have bi-monthly issue, that is total 6 issues in a year. And last 3 issues we have started printing. And I feel the journal is connecting to all our people, all 38,000 plus members. And this is provided free of cost to all our members. Now, I would like to mention over here that there are almost 800 to 1,000 journals have come back to FOXI office. And therefore, I would like to update your data on our portal. Our e-election, you are aware that the nominations are over. As Madam Agnihotri has mentioned, that now this is the election process. Nominations are over. We have sent the consent form, and now our election process is going to start. So this is the opportunity I take, that please update your data. There are 2-tier system to update your data. One is foxi.org, member.foxi.org. This is a portal where you yourself can update the data. And if you can't update it, then you just call to FOXI office, will update. Because the 15th March is the last date of updating your data. After that, we are going to close it. And the election will go to the respective mobile or membership number or email ID. So this is my sincere request to all the delegates to update your data before 15 March. Now, secondly, I would like to mention we have 263 societies, and today we can see the vibrant society of Kanpur and other societies. They are really very, very academically active. They are doing lots of CSR activities, and they are to the aim of fulfilling the mission of FOXI. For that, I really congratulate all of you for making efforts to reach our mission of FOXI. Thank you once again for taking part in this active academics and CSR activities. Then I must also mention something about Sneha. Sneha is a very sincere, meticulous worker, and since last 2.5 years, she has done fantastic job. She has been conducting many webinars, academics, and she has been doing lots of CSR activities. So Sneha, I congratulate you and I wish you best luck for the future, endeavors. I would like to mention over here, as Madam Meera Agnihotri has said, the breast issues are very, very common issue. It starts in every age of a life of a woman. And I must say that 3% of the females, they come to the physician, the 3% of the women have breast issues. It can be in a form of mass, pain, or nipple discharge. So as an obstetrician and gynecologist, we are the first point of contact. So as an obstetrician and gynecologist, we should be aware about all the breast diseases in detail. So we can treat the patient and we can give, if the timely treated, we can give the best prognosis to our women. I would like to mention that today we have eminent speakers. Dr. Alka, Dr. Pandey, Suman Pandey, and Dr. I have mentioned the other and Kanchis, that the chairperson who are going to enlighten us on this topic, which will help us in day-to-day practice, and we will help our women. So I wish I congratulate all the Kanpur and other society for the most step webinar and wish them best luck. At the end, I would like to mention Benjamin Franklin, the quote by Benjamin Franklin. Investment is the best, gives the best, dividend. So you must invest in updating the knowledge so you can give the best to your women. So with this, I would like to thank once again for giving me the opportunity. Thank you, Madam Meera. Thank you, Dr. Kanchan, Dr. Goenka, and all the other society for giving me this opportunity. Thank you very much.
Thank you very much, ma'am, for your wonderful words. You are a wonderful persona, having so much responsibility. Even then, with a loving faces, always responded to my phone call and explained all in detail. Can we have a bouquet for ma'am, Yogendra? Ma'am, this is a bouquet for you. For you, I can say she makes you, that madam, you makes every effort to supplement your faith with virtue, and virtue with the knowledge, and the knowledge with self-control and steadiness. That gives rise to godliness. Ma'am, you are great. Thank you for blessing us.
Thank you very much. Thank you.
Now, our guest of honor is Dr. Kavita Bapat. So I request Yogendra, please show the CV of Dr. Kavita Bapat. Dr. Kavita Bapat is our Vice President, VP now, and very pleasant personality, always with the pleasant faces and responding very well. Ma'am, thanks a lot. You are most welcome. You are organizing at present AICOG, even then you have accepted our invitation. She is MBBS MS FICOG. She is a director of One Center for Gynecological Excellence. She initiated registry for primary ovarian insufficiency. She got award winner of NICA Indore and captain of industry. She is a vice president. She was organizing secretary at present AICOG 2022. I think this is a old one CV, and she has got a one-day hysterectomy specialist. She is a past governing council member of ICOG. About Dr. Kavita, I will say, to succeed in your mission, you should you always have a full-heartedly effort that you do, ma'am. So you devote with full smile and loving heart, and you are marvelous, ma'am.
Thank you so much, darling. Thank you so much for inviting me today, Kanchan. All my regards to Meera Agnihotri madam. हमेशा उनका सानिध्य मिले और उनके साथ कोई स्टेज शेयर करना पड़े, ये बहुत बड़ा privilege है मेरा. I'm so happy.
Thank you very much.
I just loved the idea of K. So Kanpur, Kanchan, Kiran, Kavita, all will rock. I hope so. Thank you so much, Meera madam, for giving the idea of K today. So I'm so happy. Nice to see all the Dr. Goenka, Dr. Radhika, Dr. Sneha, my own friend, and our dear General Secretary General Madhuri Patel madam. Seema is there, Preeti Sharma is there, so many. I'm sorry I'm not including all the names, but I am seeing Taru is there. So everybody, thank you so much for inviting me. But the most important point, your topic is excellent today. As always, I like the breast, and we should not leave the domain. Like madam is talking about कि breast हमारा है नहीं है, पर हम सब इस बात को मान चुके हैं कि breast हमारा है. And Sneha is doing extremely good work, very hardworking girl and very sincere and this thing. But I have 3 questions today. Do we have the role of lactational consultant in this country? And can all our Foxians should become the lactational consultant? And lactation is so important because as the topic is there. So the lactational consultant, who should be? Do we, the breast committee's domain, that they should start some exams of the lactational consultation or something like that? So we can all think on it. We can all also can plan it. And another important point is we should not leave the breast, because as soon as the baby is delivered, the baby goes to a pediatrician, and sometimes the breast problems also being not, patient doesn't come. So it's our responsibility to check the patient's breast on the day 1, day 3, day 7, day 14, day 40. And मेरे हिसाब से तो जिस दिन तक breastfeeding चल रही है, they should come to us, and we are responsible for all the lactation and all the things. And nice to see Aarti over there and Purna also there. I'm not including all the names and everyone. So again, thank you so much. And Kanchan, Kiran, both of you, all the best for your future endeavors. And thank you so much for giving me the chance. Dr. Goenka, Dr. Preeti, thank you so much. Meera madam, बार-बार मिलते रहेंगे इंदौर में. Again, I'm getting the opportunity to invite each and every you. Radhika is also there. So each and everyone who is there, I'm really, that's, I take it as a personal invitation. और अभी से मैंने माफी मांगना शुरू कर दी है, so मेरी माफी गलतियों को समय समय पे माफ कर दीजिए. So thank you so much for all the program, and congratulations for conducting this type of programs. Thank you so much.
Thank you so much, Dr. Kavita, for your wonderful words. माफी की तो कोई बात ही नहीं है. आप तो हर काम मुझे लगता है ऐसे perfectionist करती हैं और with a laughing faces and always smiling. I love it. Thank you, ma'am. There is a bouquet for Dr. Kavita. Ma'am, this is a bouquet, virtual bouquet for you.
Thank you so much.
Thank you for accepting the
Thank you,
invitation.
Kavita, for your kind wishes.
Thank you so much. Thank you so much. Giving bouquet and meeting females like a full of bouquet. So it's a really double pleasure. Thank you so much. Thank you so much.
Thank you so much.
All of you are very much invited to Indore.
Yes, madam. And आप सबको लेके आ रहे हैं. Thank you so much.
Okay.
And all the society presidents who are joined today, I have joined through this mobile. So I have not covered everybody's name. So extremely sorry for that. But everybody is invited. Thank you so much.
आ रहे हैं धमाल मचाने.
Thank you so much.
Yes, we are all coming.
Yeah. So the next guest of honor, chairperson, national chairperson of Breast Committee, Dr. Sneha. So, ma'am, most welcome. इनकी तारीफ में तो वर्ड्स कम पड़ जाते हैं. इन्होंने इतना काम किया है इस बार फॉक्सी के लिए कि हर कोई आपका नाम लेते ही बिल्कुल भाव विभोर हो जाता है. तो पहले तो मैं इनके लिए थोड़ा सा डॉक्टर स्नेहा सुरेंद्र बुहार, शी इज MBBS MD FICOG FICMCH and she is managing director of Sukharta Hospital and teaching experience of 5 years in VNGMC Yavatmal. She has so many awards. She got National Individual Award by Foxy 2008, Dr. Anandibai Joshi Award by Government of Maharashtra in 2005, Foxy President Appreciation Award, Foxy President Appreciation Award for Exemplary Work in Cancer in 2019, Champion of Foxy 2019, International MS Signature Award, and Lokmat Health Excellence Award 2020, Asia GCC for Leadership in Healthcare, and Champion of Foxy, and so many national awards. She held official post Foxy Chairperson Breast Committee. Now she is holding. She is Governing Council Member ICOG, Founder President Vidarbh ISOPUB in 1719.
Yes, thank you so much,
So
dear
many
Kanchan.
research and publication was under her credit.
Yeah,
About
thanks,
her,
dear.
I can say, ma'am, about you, I can say the willingness to give a lot of time and energy to something because it is important, that is within you, ma'am. We all have dreams, but someone like you, in order to dream come into reality, take an awful determination, dedication, and self-discipline and efforts. Hats off to you, ma'am. Welcome.
Thank you so much. Thank you so much, Kanchan, for that warm introduction and warm welcome at the outset. Hearty thanks and thanks from the bottom of my heart to Madam Meera Agnihotri. My pranam once again. It's a pleasure sharing the dais with you. Respected Secretary General Dr. Madhuri Patel, my dear friend Dr. Kavita Bapat, all the society president, secretary, I can see Dr. Usha Goenka and Dr. Kanchan, the team Kanpur, and from Jaipur, I can see Dr. Priti Sharma and Dr. Taruchaya, from Jhansi, Dr. Sethi, and we have so many societies. I think everybody has taken their name. I just take the names of society, the Uttarakhand societies, Dehradun, Rudrapur, Haridwar, and of course the Srinagar, Jammu and Kashmir, Dr. Shehnaz and Dr. Nikhar. So I welcome you, all of you here, and thank you for inviting me here. as far as breast committee, the work, I think all of you, it's not me only as standalone doing the work, it's all of you, because all the 260 societies of FOXI, they are working. The breast committee has become so vibrant. I'm very happy to share with you that this Lactacon, we had participation of more than 250 societies out of 260, and that was a history. Yeah, I mean, it was a matter of pride for FOXI. It was first time in the history of FOXI. That is what the President FOXI has described. So it's the credit goes to all of you. So as breast committee, we are working mainly on the three aspects: breastfeeding promotion, benign breast diseases, and awareness, screening, and early detection of breast cancer. And for that, we are working at 3 levels. I have already shared with at so many other platforms that we are sensitizing the FOXins. We are making them, giving them the feeling that yes, it is our domain. For every activity, we are sensitizing them that like other reproductive organ, breast is our domain, because by virtue of our practice, breastfeeding and the problems related, or maybe other problems of the breast, the women come to us for their problems, and we are the first point of contact. That is why we should always make it a habit to examine the breast. If there is any abnormality, we subject her for further investigations. If there are no abnormality, we teach her self-breast examination and guide her about her risk and screening strategy. So that is how we have got a role of savior. We can do early detection and save the lives of the women. So as breast committee, we are working at all the 3 levels, and I'm very happy that not only the awareness, public awareness programs, but the academic sessions and the new e-newsletters, the recent updates, and so many other publications and researches we are doing under this committee. So we are working at all levels and trying our best. And thank you, all of you, for being the part of all these activities. Thank you once again, Kanpur Society and Madam Meera Agnihotri for inviting and blessing us. And definitely, I'm coming personally to have your blessings at Meerut. So thank you so much, everyone, once again for having me here.
Thank you so much for your
Of
wonderful
course,
words.
not to forget a very, very, very good luck and best wishes to both of you, Dr. Kanchan and Dr. Kiran Pandey.
Thank you, Dr. Sneha. Thank you
Thank
very
you
much.
so much. Your blessings and good wishes always made our day. And thank you so much for blessing us. There is a bouquet for you. This is a wonderful bouquet, ma'am, for you. This is a virtual bouquet.
Yes, thank you so much. Thank you, dear.
Thank you so much. Now the Dr. Seema. Now I give mic to Dr. Seema Dwivedi. She is a professor GSVM Medical College, Kanpur. She is associate professor, Rama Medical College. She was in 2002, and she is awarded with District Gold Medal and the state level awards, IMA President Award. And she was organizing secretary of quiz in UPCOG 2015 and joint organizing secretary of WWCon. Her field of interest is academics, high risk pregnancy and ultrasound in pregnancy. And she has presented papers in many national and international conferences. She is a good speaker. Above all, she is Shiv ki Diwani. हम लोग उनको शिव की दीवानी कहते हैं. She always have a bhakti towards the Shiv as she has started. So mic is yours, Dr. Seema. Please proceed the session.
Thank you so much, ma'am, for your kind introduction and remembering my Shiva. Thank you so much, ma'am. So I would like to go ahead with the webinar proceedings. Hey माँ, तेरे आंचल में पला हूँ और तेरे ही अमृत से जीवंत हो आगे बढ़ा हूँ. We are fortunate today to have a star-studded galaxy of chairpersons and speakers with us. Introducing our first chairperson, Dr. Preeti Sharma, It is my proud privilege to introduce her, a pleasant personality, a loving persona. She is President Jaipur Obs and Gynae Society. Kindly put forward her CV. CV of Dr. Preeti Sharma. She is President, Jaipur Obs and Gynae Society, Senior Consultant at Cocoon Hospital, Jaipur, visiting consultant in many renowned hospitals, having an expertise in high-risk obstetrics and advanced urogynecology and laparoscopic procedures, specially involved in maternal health care and advocacy and patient education amongst underprivileged sections of society. Our second chairperson, Dr. Aarti Luthra. It is an honor for me to introduce her, a loving persona and a pleasant personality, President Dehradun Obs and Gynae Society, Joint Secretary UPIAGE, UK Coordinator Foxy Endometriosis Committee 2021, Founder Chairperson of Uttarakhand ISAR, North Zone Coordinator Foxy Medical Disorders Committee, invited as faculty and speaker in various international and national conferences, winning many prestigious awards. Okay, for both of them.
अब इससे ब्लीडिंग रुक जाएगी. मैंने फर्क दिया, रजिस्ट्रॉन मत खाओ. तब मुझे एक बार देखने दो, ठीक है? और आप इसके बारे में पढ़ के आना, सर को कहना प्लीज.
Dr. Anupama Ravi, President, Rudrapur Obs and Gynae Society, Fellow Reproductive Medicine from NUH Singapore, owner and senior consultant at Futela Hospital, Rudrapur, executive member in various committees and societies, faculty in various national conferences, and conducting various training and workshops, and has contributed to many chapters in books. So I now request Dr. Preeti Sharma to kindly introduce our speaker for the topic of optimizing breastfeeding.
Yeah, at the
There will
outset,
be
first,
bouquet
I
for
would-
all of this. Dr. Seema, there will be bouquet for all of these chairpersons.
Kindly show the bouquet for all the chairpersons. A floral bouquet from Kanpur Obs and Gynae Society for all our beloved chairpersons.
Thank you so much. Thank you. Lovely flowers.
Thank you so much for that. Thank you, Kanchan ma'am and Dr. Seema for this invitation.
I request Dr. Preeti Sharma to kindly introduce our speaker, Dr. Kanchan
Yeah,
Sharma.
Ruchana.
Yeah, can I have her CV, please, Dr. Kanchan? Yes, it's my pleasure today to be here along with such dignitaries and I actually congratulate the Breast Society for really doing so well in involving all the societies in their projects. We know essentially that breast is an essential part of being a female, and that's why I think this topic is so very important. And about Dr. Kanchan Sharma, we know her pleasant personality. She's so proactive and so nice to talk to. Dr. Kanchan Sharma is the secretary of Kanpur Obstetric and Gynae Society. She's the president of IHRF Kanpur. She's the director and chief consultant at Akash IVF Center, Kanpur. She's an ART specialist, laparoscopist, and a colposcopist. She's a member of Foxy, IAGE, ISAR, IFS, IMA, AMS, ISOPARM, and NARCHI. She's the vice president and honorary joint secretary of cultural secretary, library secretary, IMA Kanpur. She is the has been the vice president, joint secretary, and cultural secretary treasurer of COGS. She is involved in a lot of social work as well. In the Pratigya Social Impact Award, Empowered Women Award, Nari Ratna Samman, and Corona Warrior Award, Nari Suraksha, and Nari Samman Award from Police Commissionerate, Kanpur. So welcome, Dr. Kanchan. I think you did not need this introduction, but
okay, thank you.
It's a formality to do it. She is presently the life member. And, yeah.
Thank you so much, Dr. Preeti, for your wonderful words. May I share my screen? Please stop sharing your screen, Yogenji. I think my screen is visible.
Yes, it's visible, Dr. Kanchan.
Oh, this is the last slide. So, I, Dr. Kanchan Sharma, Secretary Cox, just welcome all of you and thanks for giving me chance. The topic for today is optimization of the breastfeeding. As we were discussing, that breastfeeding is very important, and for we gynecologists, we obstetrician have to advise to our patient about the proper way, what is the importance of the breastfeeding, and all that we are going to discuss here in today's webinar. Breast milk is, of course, a gift to mankind. Mother's best gift to her baby, and it's a best vaccine provided by the nature. It has a multi-dimensional impact on the society as it confers medical, economical, social, and environmental advantage. It has no contraindications except galactosemia, active untreated varicella, or active herpes lesion on nipples. We have a separate lecture on this. Benefits of the breastfeeding, if we talk, they are to mother and to the baby. For the mother, there is emotional satisfaction. It helps in weight loss of the mother, and there is less chances of PPH, so less anemia, lesser breast cancer chances, and ovarian cancer and endometriosis. It is a natural contraception and economical to baby. It has a nutritional benefit. There are less chances of all the infectious diseases, less diarrhea, constipation, neonatal pneumonia, because it increases the immunity, lower rates of sudden infant deaths, and stronger immune system, and it is rich in vitamin A, which is very important for eye. If we talk of the global scenario, globally only 38% of the infant between 0 to 6 months are on exclusive breastfeeding. So exclusive breastfeeding can save equivalent to 8,20,000 deaths in children under the 5-year globally per year. WHO, UNICEF, they all target to increase the rate of breastfeeding 50% by 2025, whereas in India, 69% is the target. So what are the recent evidence? The recent evidence tells us that compared to infants who initiated breast within 1 hour of the birth, and infants who initiated breastfeeding 2 to 23 hours after the birth had 33% of the greater risk of the neonatal mortality. So early initiation reduces infant mortality rate also. Infants initiated breastfeeding after 24 hours, they have increased rate of neonatal mortality. So if we see the scenario that only 42% of the mothers initiate breastfeeding within the first hours of the birth, and 1 in 2 children are exclusively breastfed for the first 6 months. So they have a missed opportunity. What does Indian scenario say? That analysis of exclusive breastfeeding trends show that the percentage of infants under 6 months increased from 46.4 to 54.9% now, and the national average conceals variability across states. So 6 states, UP, West Bengal, Karnataka, Arunachal Pradesh, Kerala have showed decline in breastfeeding. Highest decline is seen in UP, so we have to work out on this all. These data show this all. Optimization means the action of making the best or the most effective use of a situation or resource. Early initiation of the breastfeeding within the first hour after the birth requires full support and commitment from health workers and the birth attendants. So exclusive breastfeeding have no additional, because in this you don't have to give any additional water, no food, no formula, no animal milks. Use skills to maintain the breast supply for first 6 months. How to optimize the breastfeeding? Early initiation of the breastfeeding is very important. Overcoming the breastfeeding difficulties that you have to guide to the patient. Breastfeeding promotion and continuation is necessary. Nutrition of the breastfed mothers that you have to see. There's implementation of IMS Act in 1992 that we will come on this. Overcoming the myths and misconceptions that is to be dealt by a different speaker. Breastfeeding friendly hospital initiative. This is very important. We will discuss shortly about it. And human milk banking. So early initiation begin if breastfeeding that begin within early first hour, deaths can be avoided. It reduces the chances of breast utilization of strong suckling reflexes within 40 to 60 minutes, which reappears after 24 hours. So within first 40 to 60 minutes, there are strong suckling reflexes. So patient should utilize this. Skin to skin contact is very important. This is for bonding between mother and the fetus. So this is, if we discuss about the major hurdles and important do's. Lack of knowledge. Why they don't start early breastfeeding? Because of lack of their knowledge and motivation and awareness among the people. So we are the obstetrician that we should induce that knowledge. The lack of support of the family members and the health professionals. We should train the health professionals and guide them. There is some of the commercial influence is there. Therefore, there is a banning of the bottles, etc. by the government. The feeling of not enough milk among the women. Many women, they do come and say that my child is hungry and his or her requirements are not being fulfilled. So they are to be guided. Nipple and the breast issues are there. Maternity leave and benefits issues are there. They are to be seen into. Important do's: initiate breastfeeding as early as possible within 1 hour of birth, as we have already discussed. Do not give the baby any prelactial feeds, no bottles, artificial treats that we have discussed. Breastfeeding on demand at least 8 to 10 times in a day and at night. Breastfeeding in a correct position is very important. So, for successful breastfeeding, important aspect of the successful breastfeedings are positioning, attachment, rooting reflex, suckling reflex, and swallowing reflex. Mothers need help when they are a first-time mother. Because when they are the primary, especially, they come to you in the clinic. This is your duty that you guide them and prepare for future breastfeeding and tell them all the issues. They are the mothers who had difficulty in breastfeeding in earlier child. There may be few mothers. There are mothers who bottle fed before and now want to breastfeed. They are the mothers with twin pregnancy. These are some mothers who have problem. Early initiation of the breastfeeding. In India, the rate is 53%. In facilities, facility delivery, and one of the missed opportunity being cesarean section. So UNICEF Global Database 2018 reveals that across 51 developing countries, EIBF, that is early initiation of breastfeeding rates among newborns delivered by normal vaginal deliveries were twice as high than those delivered by C-section. The rates were less, as also we see in our clinics. In private sectors, C-section deliveries, only 33% newborn were breastfed, because as the patient, our staff should be well trained. Patient tell their complaint to the staff and paramedics. They advise for the bottle feeding. That should not be done. While breastfeeding should be started within 1 hour, compared to 40% newborn delivered by C-section in the public facilities. So post-cesarean deliveries, what are the issues? They require support of obstetrician and OT staff and the family members later on for EIBF. Favorable positions should be there. You should advise and support them about the laid back position as shown in the figure, laid lying position, side lying position. No awareness to mothers about the nutritional requirements during the first week, which is very less. That is 5 to 7 ml of the colostrum is sufficient on the first day of the life. As I have seen saying the patient that, doctor, my breast milk is very insufficient. That is not working proper. So I have to give additional milk, but you have to tell them and guide them. Newborn has 20% extra calories in store as buffer for the nutritional adjustment. So this colostrum is sufficient for them. Successful breastfeeding positions. I have shown different successful breastfeeding feeding positions. So there is a skill. Mother learns to position the baby and baby learns to take the breast. Rooting reflex is there. When something touches the lip of the baby, he opens the mouth and put the tongue down and the forward. And there is a suckling reflex. When something touches the palate and baby sucks. And again, there is a swallowing reflex. These all are the reflexes which we need to understand. What are the signs of the correct positioning? This is very important. Baby's head and body should be in a straight line and baby should be turned towards the mother. Mother should hold baby close to her body, that is skin to skin contact should be better, and baby's neck, back, buttock should be well supported. So whatever the posture mother decide to feed, it is acceptable and baby and mother should be comfortable. This is very important that they should be comfortable so that there is effective transfer of the milk. So in this diagram, again, I have shown that mouth should be wide open and lower lip is turned outside. See, there are two positions. Just tell what is better. Chin touching to the breast. This is a proper position. Black part of the breast not visible below the lower lip, as in this one. And large black portion of the breast and the nipple, including milk collecting ducts, are inside baby's mouth and tongue under the teat. While this is a wrong position. The second one is a wrong position. So what are the consequences of poor attachment? What difference do you make in these two pictures? This is a good attachment and this is a poor attachment. This is again, what is the difference between this is a good attachment and this is a poor attachment? So poor attachment, what does it do? ये क्या करता है? Pain and damage to the nipples. So there are chances of sore nipple and the fissures. There are chances of engorgement. Breast milk not removed effectively. तो क्या होगा? Engorgement होगा. Apparently poor milk supply होगी baby को. Baby is unsatisfied and wants to feed more. Baby is frustrated, refuses to suckle. जैसे कि बहुत सी ladies कहती हुई मिलती हैं कि हमारा baby satisfied नहीं होता. Have you seen the attachment? This is very important. Train your staff. Breast milk less, baby fails to gain weight because is not satisfied. So what are the causes? Inexperienced mother, lack of skill support, use of feeding bottle, and functional difficulties. They are there. So inexperienced mother, many times they are the first baby, bottle fed previous baby, and faulty techniques. Lack of skill support, less traditional help and community support. Many times your hospitals, midwives, nurses, they are not trained. So this is in our hospital, we usually have the classes of paramedics. We have a lecture theater and we play the slides and once a week we play these type of slides and teach our paramedics. This is very important, as even Foxy has taken a step to train all the paramedics. So use of feeding bottles before breastfeeding established for the later supplement. This is important, that don't advise feeding with the bottles. There are many times functional difficulties like baby, बच्चा कम weight का है, sick है, nipple poorly developed है, there is large or flat nipple है, engorgement है. These are the reasons in which the patient think that we have to give extra feed. But we have to consult the patient and see her problem. Breastfeeding promotion and the continuation, it is combined responsibility of the obstetrician, pediatrician, staff nurses and Sayya workers who have to look after कि breastfeeding promotion हो रहा है कि नहीं. Now the breast committee, Foxy breast committee is working, and under expert guidance of Dr. Sneha madam, we all are doing to promote the breastfeeding activities. Skill of guidance should be there. Care and counseling should be antenatal, intrapartum and postpartum about the benefits and correct methods. There is some disturbance. Yogenji, please see. Care of nipples and the breast and the nutrition of mothers should be there. There is some
your voice getting echo, ma'am, at your end.
I don't have any other device. I think
because all are muted, only your voice getting echo, ma'am. That is
audio and visual clips, posters for promotion of AIBF and EBF, and promotion of milk substitutes should be prohibited. These are 10 steps to successful breastfeeding. These are BHFI 10 steps which we should all learn. The staff competency, support to mother, responsive feeding, antenatal care, supplementation should be prohibited, bottles, teats should be prohibited, and care right after birth, rooming in, and advice at discharge. This is by the WHO and UNICEF. What are the additional calories which are needed? 500 kilocalorie during the first 6 months and 400 kilocalorie for the next 6 months is recommended. It is mandatory to fulfill the nutritional requirement for maintaining galactopoiesis and effective breastfeeding. So nutritional demand should be seen. Implementation of IMS Act 1992, the breastfeeding was the best, and it is the best and will remain the best for the infant feeding. Prohibit sponsorships or giving payment to healthcare worker. It bans the advertisement and free samples. Prohibits all the forms of promotion of baby food for babies under 2 years. So IMS Act positive reinforcement is key for the success. And if you violate, there is a punishment or can be jail, which can extend up to 3 years and fine up to 5,000 rupees. Myths and misconception, that is to be taken by Dr. Kiran Pandey ma'am. And baby friendly hospital initiative, we have already discussed the 10 steps plan. Human milk banking are there. The International Milk Banking Initiatives was founded at the International Human Milk Bank Association of the North America Congress in 2005. It lists 33 countries with milk bank programs. WHO states that the first alternative to a biological mother not being able to breastfeed is the use of human milk from other sources. The primary and by far the largest group of consumers of the human breast milk are premature babies, infant with GI tract or problem or metabolic disorders may also consume this form of milk as well. So these are the list of the human milk bank in India. I'm not going in the detail. I'm not reading out the details. Overcoming barrier for working women. I've seen many times the working women have a problem that they cannot breastfeed their infant. Working women who return to work early need support to continue breastfeeding. Government, business, civil society, and family support, they are required. So provision of breastfeeding room is important, which should be clean, safe, with private space for women. The main function is to effectively express and store the milk during the working hours. There should be cold storage system that should be available. So COVID-19 and breastfeeding, I am not going to take because that is to be taken by Dr. Kiran Pandey. Thank you for patient hearing. Successful breastfeeding is not the sole responsibility of a woman. The promotion of breastfeeding is a collective social responsibility. So we all are there to bear this responsibility. And thank you all for patient hearing. Thank you so much.
Thank you,
Thank
Dr.
you so
Kanchan,
much.
for that wonderful description on breastfeeding practices. And the take home should be that, it's the onus is not only on any surgeon or any nurse on duty. It is basically the responsibility of all of us, including the doctors, the nursing staff, the paramedics, even the ayas. They all should be encouraging the patient for early breastfeeding. Thank you so much for that comprehensive coverage.
Thank you.
Congratulations, Dr. Kanchan. Really well-organized meeting. It was so nice to hear from Dr. Meera, Dr. Madhuri Patel, Dr. Kavita Bapat. And it's so nice to see Dr. Kiran Pandey with us again. And I congratulate Dr. Sneha Bure for organizing wonderful conferences on breast diseases. She did a webinar with us also, which was very fruitful. And your talk was very useful because it's very important to be breast feeding promotion friendly at all the maternity clinics. And the practice should start from antenatal time only. We have to sensitize mothers for nipple care also. When they are term, we can tell them to go for nipple massage. That helps in initiation of labor also, and that helps them feel comfortable about their body. And early initiation is the best. What I recommend is the moment a baby is delivered, we put the baby on mother's chest, and that promotes skin to skin contact. The mother is elated and the staff nurse puts the baby to breast, because the sucking reflex, as told by you, it is very good within 1 hour. So if the baby starts suckling, it's very comfortable for the doctor who's doing the procedure, whether it is stitching of episiotomy or you are doing a C-section. The mother is very happy. Breastfeeding practice has started early. And once the staff knows that the doctor enjoys baby being put to the breast, they do it every time you're delivering a baby. Because nowadays, a lot of mothers, they read so much that they want skin to skin contact of the baby, and they want the baby to take mother's feed as the first milk, which is a very good practice. And the second thing is exclusive breastfeeding for first 6 months, which is very, very important to explain to all the mothers. Another thing which I wanted to add, that rather than getting the bottle first 1 or 2 days, if the milk is not enough, or if after cesarean the mother is not able to handle the baby, we can promote Jhinook practice also. I'm sure everyone would be knowing about Jhinook, which is a big spoon kind of thing, and a lot of Bengali people, they use Jhinook for feeding the baby instead of giving bottle feed. So that way the baby is not confused between the nipple of the bottle and the mother's nipple. Because if we explain the patient about the nipple confusion, that if you'll give bottle to the baby will get confused between the mother's nipple and bottle's nipple, they understand that they don't have to give the bottle to the baby at all. And continuing the feeding for 2 years like their grandmoms did if we explain them that like all our grandmothers, they were feeding the babies for 2 years, getting back to normal figure, a contraceptive effect, and the bonding, of course they continue. So your talk was very good, of great importance to all the OBs, so that they train their staff, they take regular classes. And nowadays the easier option is what we do, a good YouTube video of Chinook feeding, you share in your hospital group, that all staff has to learn. A good YouTube video. Promote our breastfeeding practices. Congratulations once again. Very good talk, and wish you all the best for your for your dreams. Good luck to Dr. Kiran ma'am also.
Thank you, Dr. Aarti, for your wonderful
Thank you,
summing
Aarti.
up and adding few points. I agree with you, and wonderful. Now, for the other session, I think mic is again to Dr. Seema Dwivedi.
Thank you so much, ma'am. Thank you for a wonderful lecture and very valuable insights into optimizing the breastfeeding and valuable inputs by the chairpersons. The elixir of life, yet to our babies we deny. So we have a far away target to be accomplished yet. Because of the myths, the successful breastfeeding is still not initiated by many women, as ma'am has mentioned. The percentages of women not yet properly breastfeeding to optimum. So coming to the next important topic of the myths surrounding breastfeeding, I would love to introduce our chairpersons. It is my proud privilege to introduce Dr. Sujata Sharma. Kindly put forward the CV of Dr. Sujata Sharma. Dr. Sujata Sharma is immediate past president of OBS and Gynae Society, Amritsar, senior consultant OBS and Gynae Apollo Specialty Hospital, has held many prestigious posts in past, delivered more than 150 lectures and presented more than 70 papers, and has published more than 45 papers. She is past Director of Medical Education and Research, past Principal Government Medical College, Amritsar, and holds many prestigious positions in many organizations. Our second chairperson is Dr. Shehnaz Tang. Acha.
Bouquet for Dr. Sujata.
Bouquet, ma'am, floral bouquet from Kanpur OBS and Gynae Society to our chairperson, Dr. Sujata Sharma. Our second chairperson, Dr. Sandhya Sharma. Dr. Sandhya Sharma is President Haridwar OBS and Gynae Society and President NMO with more than 30 years of experience in health services, and she is member of various organizations and for more than 30 years has given service to society in maternity, infertility diagnostics and Adhyatmik Chetana. She is very active socially as well as spiritually. A floral bouquet from our side to Madam. Our third chairperson, Dr. Shehnaz Tang. She is President, Srinagar OBS and Gynae Society, ex-professor and head of department, OBS and Gynae GMC Srinagar, trained in sonology, and she started sonology wing in main maternity hospital and has started off with multiple projects and papers. A floral bouquet from our side for ma'am. I now request Dr. Sujata Sharma ma'am to introduce our speaker, Professor Kiran Pandey, for the next topic. Ma'am is not connected. Dr. Sujata Sharma.
She was here. I was seeing her. Dr. Sujata ma'am.
हाँ.
आप इंट्रोड्यूस करने के लिए किसी और से कह दो. Till I thought she was there.
So I request Dr. Sandhya Sharma to kindly introduce Kiran Pandey, ma'am.
आई थिंक कोई कनेक्टिविटी इशू है या फिर हम लोग का
Okay, I request Dr. Kanchan Sharma ma'am to introduce Professor Kiran Pandey.
Yeah,
Some
this is my good luck, Professor Kiran Pandey. You are so near to me. You have been my teacher also in medical college, and you are very dear to me, ma'am. My all the respects to you. You are MBBS, MD, FICOG, FIM. SA, FICMCH, MAMS. She is a professor and head of department since 2004 in Department of OBGY GSPM Medical College Kanpur. She is ICOG Governing Council member 21-22. She is president of Kanpur Menopausal Society. She is a chairperson of IMA WDW 2019 till date. She is a vice president of UPCOG and ex-principal GMC Kannauj. She is ex-president Cox and IMA. Her work experience is very vast. She had active participation in all the activities of FOXI from 1986. More than 36 years of the teaching experience, contributed chapters in various books and organized many workshop, conferences and seminars. There are so many awards for you, ma'am. Awards, 15 national and 10 state level and 10 district level awards, and more than 40 awards by IMA and Rotary Club. Received Best Teacher Award, received President Appreciation Award, received GYTI Award and Rashtrapati Bhavan Award. Ma'am, you are one in all, and I have lot much of love and regards to you. Now stage is yours. Please,
thank you, Kanchan, for very, very kind words. And actually, it is my proud privilege that you are introducing me. And it looks so nice. As you said, I have been your teacher. Yes, that's another you are a feather in my cap.
Thank you.
To the so much heights.
Greatness, ma'am.
So let me share my screen. Can you see my screen?
No, not yet.
Okay, sorry, just a minute. I'll escape, I'll go back. This is a problem. Something always happens.
Plus, first click on share screen.
No, I will know, I will do. But I have actually lost it. Give me a minute. You'll have to give me a minute because it has gone on from the dais. So I'll have to windowize the window. Then
मैम कोई प्रॉब्लम हो रही है तो योगेन को दे दीजिएगा, फिर वो रन कर देगा.
नहीं, वो कर तो देंगे, बट मेरी से क्या हुआ है, एक मिनट नहीं, आप मुझे जस्ट गिव मी 2 minutes, कहीं कुछ गड़बड़ हो गई है. हाँ, ये है. How come that is not visible, na? डेस्कटॉप पे क्यों नहीं आ रहे हैं?
आपका प्रेजेंटेशन खुला हुआ है?
खुला था, बट वो हुआ क्या?
इसको
खोलना ही तो था ना.
एस्केप दबा के पहले उसको खोल दीजिए.
हाँ, मुझे वो सारा का सारा वो वापस नहीं जा पा रहा है, पता नहीं क्या अटक गया है। अच्छा मैं रुको इसमें से करती हूँ फिर से, ये लीव करना पड़ रहा है साइट को।
लीव कर दीजिए, दोबारा इसको खोल के फिर दोबारा से लॉगिन कर लीजिए।
मैं भेजूं क्या दूसरा किसी को? नहीं,
योगेंद्र को भेज दीजिए।
हम भेज दीजिए योगेंद्र को, वो रन कर देगा।
जस्ट अ मिनट, डाउनलोड्स पे आ गया।
डाउनलोड्स में अगर लास्ट है तो उसको
हाँ,
डबल क्लिक।
अच्छा खासा मैंने सेट करके रखा हुआ था और यस नाउ मैं इसको यहीं से मैक्सिमाइज कर देती हूँ।
अब शेयर स्क्रीन पे जाइए।
पहले ये इधर तो आए। हाँ, नहीं ये नहीं आया अभी। Is it visible now?
हाँ हाँ बिल्कुल, अब इसको फुल
हाँ,
स्क्रीन
बट
कर
फुल स्क्रीन करने में ही एक्चुअली वो चला गया था। मैं
आपने कोई और बटन प्रेस कर दिया होगा, उसका रीडिंग वाला देखिए पढ़ के स्लाइड शो।
हाँ, नहीं वो तो है, मैं देख रही हूँ। देखो फुल स्क्रीन हुआ है?
नहीं
एक्चुअली मेरे कुछ फोन में ही वो हो रहा है कि फुल स्क्रीन नहीं हो रहा है, इसीलिए मैं उसको छोड़ रही थी। क्या करूं?
ठीक है ऐसे करो।
अभी दिख रहा है?
हाँ दिख रहा है।
हाँ मैम दिख रहा है।
नहीं दिख तो रहा है, लेकिन अब ये मेरे सामने क्या आ गई? मेरा ये जो सीवी हटवाओ जरा सा।
सीवी हटा हुआ है, आपका आ रहा है ब्रेस्ट
हाँ,
फीडिंग स्पेशल कंडीशन आ रहा है।
मुझे तो नहीं दिख रहा। मुझे
आप क्या प्रेस कर रही हैं आप?
हम लोगों को दिख रहा है।
नहीं, लेकिन ये मेरे सामने जो ये आ रहा है ये तो ये हटे ना।
नहीं फिर आपने वो कर दिया।
हाँ,
स्टॉप शेयरिंग कर दिया।
नहीं मैं अब दोबारा शेयर कर रही हूँ। अब दिख रहा है?
दिख रहा है।
ओके, व्हाट आई विल डू कि मैं इसी को एनलार्ज कर देती हूँ कि एक बार मैं कोशिश करती हूँ फुल स्क्रीन की, अगर हो जाए। नहीं, फुल स्क्रीन पे ही पता नहीं मेरा वो आ जा रहा है। हाँ अब आ गया। इज इट विजिबल?
फुल स्क्रीन नहीं है।
अच्छा ठीक है, ओके, थैंक यू। फाइनली आई एम सो सॉरी, आई एम वेरी सॉरी। समटाइम्स इट हैपेंस, one wrong move and you go ahead and you lost. Well, thank you Kanchan once again, and all my chairpersons for giving this opportunity. Thanks to Dr. Madhuri Patel, Dr. Meera Agnihotri ma'am, Dr. Kavita Bapar, Dr. Sneha, and all my chairpersons for giving this opportunity. Kanchan has already shared all the vital informations about what the importance of breastfeeding, optimizing it, and various good insights she has already given. So let me just start with this. What ACOG recommends exclusive breastfeeding for first 6 months. Just to revise you, with continued breastfeeding, while complementary foods are being introduced during the first year of life. Now, this is a breastfed infant and healthy infant, just to show you. Now, some information into the data, most important, various data has been shown already by Kanchan. Only thing which I wanted to highlight, are you able to see my slide? Just confirm.
Kanchan वाला दिख रहा है अभी आपका, ब्रेस्ट फीडिंग इन स्पेशल कंडीशंस, सिर्फ ये दिख रहा है मैम।
अभी केवल टाइटल स्लाइड दिख रही है मैम, केवल टाइटल स्लाइड। आपके मूव नहीं किया कोई भी स्लाइड?
अभी नहीं करिए कोई मूव?
नहीं, केवल टाइटल स्लाइड पे अटक गया है। आप मैम या तो योगेंद्र को भेज दो, वो कर देगा उसको। टाइम काफी वो हो रहा है मैम।
हाँ आई नो, मैं कैसे रुको फिर मैं
मैम। एक्चुअली योगेंद्र सर अभी हिज लेफ्ट, वो घर से कंटिन्यू करेंगे। आप मुझे मेल कर दो
लेकिन
यहाँ
मुझे
पे
आपकी मेल नहीं पता
हाँ,
ना, आप
मैं मेल आईडी आपको बता रहा हूँ।
एक्चुअली इसके
आप-
बाहर क्लिक करिए, ये आपका डॉक्टर किरण पांडे वाला जो कॉलम है ना वो सिलेक्ट हो गया, इसलिए आपकी नेक्स्ट स्लाइड चेंज नहीं हो रही है। इसी स्लाइड पे कहीं बाहर क्लिक कर दीजिए, एक बार एरो से क्लिक कर दीजिए, तो ये आपका ये चला जाएगा, फिर देन यू विल बी एबल टू चेंज द स्लाइड।
अभी दिख रहा है?
नहीं, आपका चेंज नहीं हो रहा है मैम।
तो मैं फिर स्टॉप शेयर कर रही हूँ। अब ये
मैम,
मुझे, आप मुझे
मैंने अपना भेज, चैट पे भेजा है इसने अपना।
मैम चैट बॉक्स में मैंने मेल आईडी भेजी है, आप मुझे भेज दो।
वो तो और बड़ा वो है इशू। अभी क्या हो रहा है, दिख रहा है? हेलो,
दिख रहा है
चेंज
बट
नहीं हो रहा है।
मैं इसको थोड़ा सा बढ़ा देती हूँ यहीं से साइज, तो आपको शायद दिख जाए।
नहीं नहीं, नेक्स्ट नहीं हो रहा, बढ़ तो गया लेकिन नेक्स्ट चेंज नहीं हो रहा, अब चेंज करिए ना।
एक मिनट रुको, देखो चेंज, रुको, चेंज हो रहा है?
हाँ अभी हो रहा है मैम।
तो मैं इसी को थोड़ा सा बढ़ा देती हूँ बजाय वो करने के।
अब हो रहा, हाँ हो रहा है, अब हो रहा है मैम।
अब
हाँ।
सेकंड पे जाइए जी।
अब हो रहा है मैम।
इज इट ओके? इतना ही कर लेते हैं।
हाँ ठीक है मैम, पर्याप्त
है ना, दिख रहा है ना?
हाँ
इज
मैम।
इट नाउ? अब
हाँ,
देखो चेंज हो रहा है ना? ओके
हाँ मैम हो रहा है।
sorry. So these are the breastfed infant, and the data which I wanted to show you is, the important thing is that in spite of so many awareness programs and so much emphasis, the rate of early breastfeeding during the 0 to 6 months has fallen from 53.7, which was in 2015, to 51.5% in 2020. So that's the scenario actual it is. And according to ACOG, only 25.4% of women actually exclusively breastfeed till 6 months. And that is the scenario. This is what I just wanted to emphasize. Rest of the things we will not go. Now, there are various types of breast milk: colostrum, transitional milk, mature milk, preterm milk, fore milk, hind milk. Many things Kanchan has already talked. What is the most important thing is that we should motivate the mother before from the birth only, as Dr. Kanchan has highlighted, the right place of delivery, avoid unnecessary use of drugs prior to delivery is also very important, because it may affect the breast milk formation. And then initiation, of course, soon. Colostrum is very important. Pre-lactal feeds should be avoided. Good position, demand feeding, and continue as long as the baby wants, which is already emphasized. Now, as early as possible, we have already told you. I will, this is the slide actually, which I wanted to show you a little bit, that here is how the reflex is there, the two hormone, which actually when the baby uses rooting, suckling, or swallowing reflex, then the tactile response goes to the hypothalamus, and then from there to the anterior and posterior pituitary differently. From the anterior pituitary, prolactin is liberated, and which stimulates the secretion by the cuboidal cells in the acini of breast. Whereas from posterior acini, oxytocin is secreted, and which causes the let out reflex. So this was the basic thing. Now, what I will first like to talk about the special conditions where the breastfeeding is sometimes become a problem, or the mother is not very sure what to do. So when the baby, there are two types, maybe the mother is ill or maybe the baby is. If the baby is ill, actually we have to remove this myth, because this is, breast milk is the easiest digestible food. So for the ill baby also, and sometimes it can be a life savior. So we have to emphasize upon it. Now, of course, it is satisfying both nutritional and fluid demands, have protective and immunological factors, as we all know. Breastfeeding continued in most illnesses like rhinitis, diarrheal diseases, respiratory infection. It should be continued. There is no need, because it will provide immunity and protective effect. But GI contraindications to oral feeding, if they are there you have to discontinue. Now, if the baby sucks with less vigor, then more frequent feed should be offered. If the baby cannot suck, then express breast milk also have to be given, but do not avoid it. Now, there are certain situations like cleft palate or muscular weakness. Now, the slides are visible. Hello?
Yeah, they are visible, ma'am. They are
Okay. So cleft lip palate, what has to be done? Mother should hold the baby in upright sitting position with legs on either side to make swallowing easier. And can also, if not possible, then baby can be fed by the cup, spoon, until the surgical benefits are available, like surgery or something is done. Dr. Aarti was just talking about that Goodwick method. It comes with the different names in different societies, but that has to be, it has a very good replacement it can be. Muscular weakness, if the baby is like in cases of restriction, growth restriction or preterm, where baby is not able to suckle, then use dancer hand position to help the baby attach to the breast as shown into the diagram. And usually these babies feed slowly. So they may also need some feed from the cup or the tube also, express milk only, which is the extra one. Now, there are, in these certain situations, like according to gestation, if the baby, what has to be done, what feed has to be given, how, when. Like more than 36, everything is normal. Breast milk, by breastfeeding, start within 1 hour and continue for 2 to 3 hours. But if the baby is of low birth weight, like 32 to 36 weeks gestation, then breast milk, expressed or suckled, both these options can be there. Cup, spoon, paladi. Paladi is also the same thing as good milk. In addition to the feeding by the breast, this can extra used, can be. Within 1 hour, you should start, and if need be, baby is clinically stable, 2 to 3 hourly breastfeed can do. Now, if the baby is of less than 32 weeks, then baby is not able to suckle, and many a times the baby is in the NICU or something, then express breast milk is good for them. Intragastric tube can be used, start within 12 to 24 hours after the birth, and these babies may need even 1 to 2 hourly feed. Now, breastfeed in certain tissue like twins. The mother basically need help, and the best way how to hold the two babies. You have seen different kind of the latching positions, how baby can be put. She can feed both the babies together, one from each breast or one by one, whatever the suits to the mother can be done. Now, if the baby has, supposing jaundice, like there is an early jaundice, that is a physiological jaundice. This, in fact, breastfeeding reduces the severity of physiological jaundice. So there is nothing which has to be avoided. In case of prolonged jaundice, which may be sometimes because of the breast milk jaundice also, one doesn't have to worry. It starts from 7th day, continues for a few weeks, but then gradually it passes away on its own. So feeding has not to be stopped because of this jaundice. It usually goes. Of course, consultation with an ICU specialist, the neonatologist, is very important in these situations. Now, when the mother is ill, like breastfeeding, can be continued in most of the maternal illness. That is what I wanted to emphasize, like even viral fever, UTI, breast sepsis, tuberculosis, hepatitis B, HIV. I'll talk about this. Now, viral fever, supposing mother is having a very high temperature. Now, what we should advise, we have to ask her to mother take paracetamol or whatever has been advised. Feeding should be done 2 hours later when the fever subsides. Similar way in UTI, patient is given the, of course, antibiotic, etc. Control the fever, and after that it has to be given. Breast sepsis, if there is one side there is a problem, it can be done from the other side. Now, cesarean section already something has been talked about it. Just to tell you few more points. Now, in case of spinal anesthesia, the breastfeeding can start as the normal way, like the vaginal delivery. Within an hour, we to put the baby, in fact, on the table. This was a project came into our department, and then we started doing that. We put the baby on through the breast at the time of cesarean section, and as was being discussed, that this gives mother a diversion, and she becomes so happy, and then the uterus contracts, and the PPH is also less in these cases, it has been seen. If the GA has been administered, it has to be started immediately after. It can be started immediately after birth if a caregiver is available, and almost all the time mother-in-law or mother or sister, somebody will be there, and it has to be care, they have to take help. Now, as soon as the mother becomes alert, which is usually 4 hours, it can be done by her own if other possibility is not there. If the baby is small or sick, in those cases, alternate feeding has to be considered. Now, the feeding in cases of tuberculosis. Now, this is a very, very important situation. Many a times the mother and the family whole everybody is worried about it. Now, it is contraindicated until completion of 2 weeks of maternal chemotherapy in Western world, because there the facilities are more. But in India, we do not follow this. If the mother is on open case of tuberculosis, chemotherapy, I mean, the same ATT regime is started, and baby is also put on the chemoprophylaxis with INH and rifampicin. After 3 months, ensure that the mother has become sputum negative, and then we do the Montoux test of the baby. If the test becomes negative, then chemoprophylaxis to the baby is stopped. If Montoux test is positive, then we continue the chemoprophylaxis for 6 to 9 months, and feeding is continued. So this is like in tuberculosis cases, this is very important. At the same time, mother is also advised to put mask, and if she is an open case of tuberculosis, and for the rest of the time, baby is kept at a distance from the mother. So with these precautions, we can continue with it. Now, in cases of hepatitis B, the feeding has to be given without any exception. Only thing is, we give active and passive immunization both. Passive in the form of immunoglobulins, and the hepatitis B vaccination of the mother has to be done. And with few precautions, mom can do the safely breastfeed. Like then in HIV, what has to be done? If mother is taking treatment properly during the pregnancy, the breastfeeding will keep the baby free of HIV. It has to be like the present recommendations in cases of HIV is that as soon as the mother is diagnosed of the HIV in any trimester, immediately the ART prophylaxis is started. And so if the mother has taken good amount of prophylaxis throughout the pregnancy, then very less chances of transmitting the HIV to the baby is. So this, I'm sorry, because we can't do the full, so that is the problem. Anyway, transmission is almost seen to be in the babies around 5 to 10% cases. In the Western countries, we do not advise the breastfeeding because they have the possibility of taking but in other countries where breastfeeding is only allowed in those cases if the AFAS, breastfeeding, top feeding is allowed only when it is a AFAS. That means affordable, feasible, and sustainable, and it is affordable, feasible, and acceptable, and sustainable for the 6 months, because we don't realize that dibba of milk, which is from the top, it comes more than 5, 6, 700, and it doesn't go for more than a week. So if we see the cost effectiveness in 6 months, it will go very high. Now, in those cases, if the mother is having mastitis, abscess, fissure, or especially if the pus is oozing out, blood is there with the HIV, then definitely the feeding has to be discontinued. Now, there is one more thing. All of you must have been heard that mixed feeding is not allowed. Either exclusive breastfeeding or the top feeding. Now, why? The reason is when the baby receives the breast milk and other foods or liquids which contain foreign pathogens and antigens, they displace the breast milk. Milk becomes stasis and the breast permeability is increased and the sodium is increased and mastitis occurs. And now with mastitis, the viral levels in the milk are elevated. And so definitely the chances of transmission will increase. At the same time, in this, with the mixed feeding, infant gut damage occurs and inflammation. And their contact between the virus and infant blood stream is increased. So again, the chances of transmissions are increased. So please make them very clear that mixed feeding should never be done in cases of HIV. Now, sometimes mother is suffering with the postpartum depression. Now, here the relationship is bidirectional. While breastfeeding decreases the risk of PPD, but at the same time, rate of breastfeeding decreases in PPD. So what we have to do, we should consult the psychologist or the psychiatrist, and we have to see that we have to give only those medications which are safe during the pregnancy, and those who are not safe during the postpartum period should be avoided. Now, the substance use disorders, women who use non-medical drugs like cocaine, phenylcyclidine, marijuana, these are common now in the metro cities, so they should not be used. Alcohol intake, again, now has become an important point to be told, that no more than 0.5 gram alcohol per kilogram body weight should be consumed. In fact, so what I would personally like to say, no alcohol at all. But if somebody is by taking it, then at least minimum of 2 hours of gap should be there in between the alcohol intake and the breast feedings. That's very, very important. Now in COVID already, it has been talked about. The basic main point is that according to UNICEF, the COVID-19 pandemic breastfeeding advisory says that follow the 3W rules: wear a mask, wash hands, wipe and disinfect surfaces, and continue with the breastfeeding as such. Now, breastfeeding and other medications. Now, if there are patients are taking some medications in the form, so as I told you, in this case, we have to find out more information that they are being secreted in the milk or not. If they are not expressed in the breast milk, they can be continued. Otherwise, we should try to change them on a safer alternative, which is not being or minimally secreted into the breast milk. Antibiotics and NSAIDs can be administered as indicated. Now, if supposing the patient is taking opioids, then shift her to non-opioid analgesics. By any chance, if it is must to use opioid analgesics, then observe the baby that baby should not become excessive sedation. Now, if for something, imaging studies, if the contrast has to be used, the breastfeeding can be done safely. Please continue with it. Of course, inform and discuss with these radiologists which dye has to be done and what to be done, but don't need pump and dump theory. So you can continue here. Now, in critically ill patients, this is the condition where mother is critically ill. So then till mother is stabilized, then she has to be re-evaluated for lactation status. Mother who has chosen to bottle feed the infant, then the mother should initiate the nursing care measures to suppress the lactation, because otherwise breast will engorge and the infection might occur. Now, mother who has been chosen to breastfeed, nursing staff should have the proper knowledge now how to re-establish the milk supply, how to do the expression of milk, how to avoid engorgement, and actually start it. So these points, if properly taken care, even in critically ill patients, when they become stabilized, breastfeeding can be again started. Now, working mothers, already it has been discussed that importance of it has to be told, and in fact government has also realized. Initially, they were giving 3 months maternity leave, but now government has understood and giving 6 months of maternity leave, and the purpose is only because they want 6 months of exclusive breastfeeding has to be focused. Now, the only important thing, it has to be done. We all need it because the time has been little bit wasted. So I will not go into the details. You all know how to express it. Still, just few points that the hygiene has to be maintained. Breast has to be cupped in a C-shaped manner, and squeezing and relaxing method has to be used, not the sliding on the skin, because that will damage the softer skin. And when the flow of the from one breast stops, it can be done on the other. Now, this can be done manually or it can be done. Very good pumps are these days available, and they also help you for the expression of the milk. And this milk can be stored. Now, this is a very important slide which I would like you to see, that if you want to freeze, like supposing it is a freshly pumped breast milk, and if you are keeping it at room temperature, then it can be kept for 4 to 6 hours. If it is a thawed frozen to ice pack, it is kept in the frozen ice packs, the 24 hours you can keep it. If it is kept on the fridge, which has a temperature of 4 degrees, then it can be kept for 8 days. And if it is a freezer, it can be kept even for but the freezer has to have the temperature of minus 18 degrees centigrade, and there it can be kept for up to 6 to 12 months. Now, if a thawed breast milk is there, once it has been taken out from there, then how to use it? It should be utilized within 1 to 2 hours. Frozen ice packs, this should not be again stored. Fridge, it can be kept for 24 hours. But the most important thing is never refreeze it. Once it has been taken out, thawed, then use it. Otherwise, it will go waste. Now, sometimes if the baby likes cold milk, then you can give it straight from the fridge. Otherwise, their warmers are available, or you can put it into a warm water and bring it to a room temperature, and then it can be given to the baby. Now, there are certain other type of problems like flat or inverted nipples, sore nipples, mastitis, breast abscess, breast engorgement, blocked ducts, and there is not enough milk, which is a common complaint by every mother. So breast engorgement. Now, the thing is, in these cases, there is a bilateral breast fullness. Full fullness, not at one side. And this usually occurs into 3 to 5 days postpartum. Mother, when we are counseling, when we are telling her about the importance of breast milk, at that time only we should give them this idea that the breast engorgement is a normal thing and will occur. Now, it is a reassuring sign also, that this will give confidence to the mother also, if you tell them that this is a sign that the mature milk is being produced by the mother. According to the ACOG committee, they say that in cesarean section cases, the engorgement may occur 24 to 48 hours later than those who give birth vaginally, meaning by it can be from the 4 to 7 days, it can occur anything. Now, more important things we'll talk. Clinical red, swollen, warm, hard breast will be there. And that what is the treatment? Moist heat will, warm with the warm water will help them. early milk expression, and this will prevent the engorgement, and the patient needs pain reliever, then paracetamol can be given. Excessive milk emptying, if too much of mother becomes little phobic and keeps on all the time emptying manually or by breast pump, that this can also lead to oversupply. So it has to be optimal and you have to guide them. Now, flat or inverted nipples, as someone also talked about it, that the nipple massage should be started early and should be told. Sometimes there are protactile nipples. Normally it gets stretched out when the baby suckles. But sometimes they are non-protactile, they doesn't get stretched out, and instead tip goes in. Now, if this problem persists, initially books say that inverted syringe technique and double syringe technique, but in fact, now these techniques are not being used actually. In fact, these breast pumps, they do help, or the nipple shield. This will help better way in these cases. Many a times, because the patients come to us in the end, in the labor only, or late part of the antenatal period. So one doesn't have a time to give any other treatment. Sore nipples or cracked nipples. This basic reason is incorrect attachment. When the baby is not being breastfed into the proper latching position, which has been shown that how the chin should be close to the skin, there should be no gap, and the baby should have the areola into the mouth, not only the nipple. So if when the baby will suck vigorously, then physical trauma will happen, nipples will crack, and of course then infection will settle down and mastitis will occur. Sometimes what happens, the baby is, this specifically occurs in little older babies when the teeth starts coming or the gums become hard, and then baby might have tendency to bite on the breast, and mother suddenly pulls the baby away from the breast, and that time the injury may occur. Sometimes there will be oral thrush, and if there's such type of thing occur, first thing, of course, correct the position of the baby while feeding. Hind milk, which I told you many types of milk are there. Hind milk can be applied after the feed. And for infants who have had an oral thrush, 2.5% gentian bonnet can be applied to the baby's mouth for 5 days daily until the 3 days after the lesion heals, and 0.5% daily over the mother's nipple also daily for 5 days. So this helps in healing. In the market also, nystatin suspensions and creams are available, which also can be used. Now it is different, this the breast abscess, this is different from the engorgement, because this affects one part of the breast, but engorgement affects the whole part. And this is common in first 2-3 weeks of delivery, because mother is not very clear about it, how to express, and has the breast been completely evacuated or not. Persistent engorgement due to blocked ducts or infection will lead to mastitis, and finally the abscess. The area as it looks like into the diagram will be red, hot, tender, swollen breast, high-grade fever will be there, and the counts will be increased. Treatment is, milk has to be removed, antibiotic therapy has to be given, symptomatic treatment, and some antibiotics might be needed, and sometimes, if needed, surgical therapy before, because breast has a fatty tissue, and if infection is there and is not treated in time, it goes on expanding very quickly to the whole breast. So if the pus formation has started, surgical drainage becomes the essential thing. Now the blocked ducts. If improper suck towards a particular segment is there, then that duct can become the blocked, and painful hard swelling will develop on that area. Thick milk becomes accumulated and lactiferous duct is blocked. Treatment is improved removal of milk from that segment by holding the infant with the chin in such a tilted way that it points towards that affected segment. And of course, then it is expected that that duct will be opened up. Tight clothing is always never preferred during the breastfeeding. Now, benefits have been discussed, so I will not go much about it. Only thing, PPH I have already told you. And the one thing which is against the common myth that the girls these days are worried that their figure will go bad, but in fact, it is the opposite. Those females who breastfeed the baby properly for 6 months or even 1 year or more than that, they don't have to do any exercise or otherwise. They burn out extra fat very smoothly during the breastfeeding. It also lowers the risk of ovarian and breast cancer. And for 6 initial months, it can also act as a LAM, which is a contraception method. Baby always gets the nutritional benefit, immunity as discussed, and because it has a low osmolality, so kidney solute load on kidney is also less, and they have a most important thing, they are less likely to become obese, and they have a very good effect on the weight, ears, teeth, lung, tummy, bladder, immune system, all are protected. So that's they are the extra advantages. Now, but all this, besides it, few contraindications are there. I'll just like to talk and just HIV in the developed world is taken as a contraindication, not in our country. But if the mother is having active HSV infection of the breast, or she's on chemotherapy drugs, infant galactosemia is there, actively untreated tuberculosis. I've told you about tuberculosis if the proper treatment is being given, but untreated tuberculosis or drug abuse, cocaine, heroin, etc., or like mother is alcohol addict or something, in these cases, breastfeeding becomes contraindicated, unfortunately. Now, just a word about few myths, though they are very simple. Sometimes we all deal with it into the patients. If the mother is having bland food, mother feels that she can't have good food or anything, only has to take bland feed, nothing like that. She can have all the food unless and until she's allergic to something. But of course, she has to take care that the food should be easily digestible and no infection should go, because that will go to the baby also. Then you all know that need to every too early, it basically is a demand feeding. Then basically, if some people say if you feed for 1 year, then it is difficult to wean. No, nothing, no evidence like this. If properly weaning can be done without it. The baby will refuse the feeding from the, if she gets breast pump, expressed milk from the pump, then refuse the breastfeeding. No, baby generally can easily switch over with. Most natural and reliable form of birth control throughout, no, you have to take care. It is for 6 months and with all 3 important precautions of LAM, only then it works as a contraceptive. In case of breast infection or blocked tubes, I have already cleared in detail. Another very important concept, sometimes the young girls who undergo breast reduction surgery or augmentation surgery, they feel they cannot breastfeed, it will be affected. No, modern day implant techniques don't interfere with the breastfeeding. That's how the surgeons do take care. If some feel that their breasts are small, that's why they will not have enough milk. No, again, when you feed, then the glandular tissue increases. So regardless of size, one can have a very good breastfeeding. Now, already Dr. Kanchan has talked about the international milk banking, and she has told you the various centers where currently 14 centers are there. What I wanted to tell you that these basically are used for those babies who are preterm or their mother is critically ill, or in those cases where some unfortunate thing has happened with the mother and the baby needs feeding, there these banks have a very good option. And one good news about this also, that proposal from our department has also gone from the GSVM as a second center after KGMC for human breast milk bank. And unfortunately, because of COVID, our building has converted into COVID. But as soon as the building is handed over to us and the proposal gets up, is in the fire, has gone to the reached up to the Delhi. So then it's through the ICMR, and most likely in our department only we will start the breast milk bank. So finally, what is done in this, the breast milk is pasteurized at 62.5 degrees centigrade for a period of 30 minutes, or stored at -20 degrees centigrade in tightly sealed containers for 3 to 6 months, and clear-cut expiry date has to be mentioned on that. Now the one word about the galactodox, and then I will stop with it. Galactodox, many companies are coming about for this, and we have to understand how they do it. Now these are the substances and medications which are believed to assist in initiation, maintenance, and augmentation of maternal milk synthesis. Like domperidone, metchlorpropamide, we are using many times in cases of the post-cesarean or some other cases when the milk is not there. Herbal galactocox also we have been using, fenugreek, which is methi, fennel soft, and milk thistle. So they are being used as a galactocox. But they have to be, they are useful in those conditions when women feels that she's not able to produce milk, or sometimes the baby has been adopted, or some other specific situation is there, then they can be useful. But they are not the first line therapy, because enough research is still not there. And if you say evidence wise, then the data is insufficient. So we should use only those which are being used commonly in our house as a herbal. The rest we have to wait for till the evidence comes that they can be used or they are really producing the enough milk. With these words, I thank you. The breastfeeding, a boon for baby and mother, and should always be the first priority, and we should increase the incidence as much as possible. Once again, I'm sorry for little inconvenience which has happened because of the sharing. I hope my slides could be seen and I could deliver the important messages.
You could deliver the important message, and this was a wonderful and elaborated presentation. Now I think our panelists are waiting and they have to go to clinic also. They are messaging. So
okay.
Thank you very much for a wonderful presentation. Dr. Seema, this is a bouquet for you, Dr. Kiran Pandey ma'am.
Thank you very much. Thank you, Kanchan, and thank you, Usha, for giving me this opportunity. And thank you all the chairpersons, probably because of their important commitments, they are not there. But I'm sure their blessings and their good wishes are with us.
Sure, ma'am.
Thank you so much, ma'am. Thank you for a wonderful
presentation,
lecture. Without wasting much
covered
time.
every aspect. Very thorough presentation, Kiranji.
Usha, thank you, Usha.
You have covered every aspect. Very nice.
Yeah.
Thank you.
Thank you.
Now,
Thank you, ma'am. Without wasting much time, we go ahead with the panel discussion on nipple discharge, for which our expert is Dr. Usha Goenka, ma'am. It is my proud privilege to introduce her.
Such an introduction ho gaya. Bas, enough.
Thank you, ma'am.
Time mat kharaab karo, aage badho.
Ma'am.
Go ahead.
She's a strong and steady support of COGS family, always encouraging us to perform our best. Going ahead with the introduction of our moderators, Dr. Kanchan Sharma and Dr. Reshu Agarwal. Dr. Reshu Agarwal, again, is a budding oncologist. She has been felicitated with many awards. She has more than 15 publications and many research and projects to her credit. Coming to the introduction of our panelists, our first panelist is Dr. Radhika Achuri, private practitioner at GR Hospital, Dehradun, current Secretary Obs and Gynae Society.
Dr. Radhika, CV of Dr. Radhika.
CV of Dr. Radhika. Previously worked at Doon Government Medical College and previously assistant professor in Subharti Medical College, Meerut. Our second panelist is Dr. Taru Chhaya, Director, Bansal Hospital, Jaipur, visiting consultant in Cocoon Surya Hospital with special interest in all arenas of OBS and Gynae. Our third panelist is Dr. Pawan Preet Maan, consultant at Amrit Hospital, Rudrapur, well-known laparoscopic and vaginal surgeon with keen interest in infertility and high-risk obstetrics, founder and present secretary of Rudrapur Obs and Gynae Society. Our fourth panelist is Dr. Nikhat Firdaus, senior consultant Obs and Gynae, ex-professor and HOD Obs and Gynae, GMC Srinagar, secretary Srinagar Obs and Gynae Society, and counselor in IGNOU. Our fourth panelist is Dr. Shelly Agrawal, Professor Obs and Gynae, GSVM Medical College, a multi-talented personality, convener, Basket for Beginners Workshop in Lucknow AICOG, Scientific Secretary, WWCon International, and Master Trainer in many ongoing training programs. Going ahead with the panel discussion on nipple discharge, I hand over further proceedings to our moderators, Dr. Kanchan Sharma and Dr. Reshu Agarwal.
Please stop sharing. Yeah, I think all the panelists are there. I see Dr. Shelly, Dr. Taru, Dr. Reshu, moderator, is there, Dr. Radhika is there, and Dr. Nikhat. Dr. Nikhat is there. I think she was here. Dr. Nikhat is there. Yeah. So I just start sharing my screen. Welcome all the panelists in the session. I'll start sharing the screen. My screen is visible?
Yes, ma'am.
My screen is visible?
Yes, it is.
And slides? I think
Slides are in the, they are in the, आप slideshow आ गए मैम, ठीक है, okay.
Slideshow आ गया ना? Yeah. So, to succeed in your mission, you must have full-heartedly devotion to your goal. So we are all obstetrician are, as we discussed, having full-heartedly approach towards the making more and more breastfeeding approach. And now just to promote, we should know what are the type of nipple discharge and what are the physiological and what are the pathological one. And we should, therefore we have planned this session just to discuss. And my first case is a 32 years old Paris non-lactating lady with no known comorbidities. She presented with a complaint of pain in both the breast since last 6 months. The pain is intermittent in nature and increases in premenstrual phase. As such, there is no spontaneous history of any nipple discharge and no history of any palpable lump. Her menstrual cycle is very regular and family history, no positive history of malignancy in the family and no surgical history. What happens on examination? The patient comes to us that while pressing, there is a yellow-brown scant thick secretion which expressed out from the right nipple. So my question to panelists is this nipple discharge pathological or physiological? is this a nipple discharge or not? What is the nipple discharge and what type of secretion is this? My first question to Dr. Shelly Agarwal.
Good evening, ma'am. Good evening, ma'am. As far as the findings suggest, on examination there was no positive finding, and she has not complained of any discharge per se. It was not her complaint, but when we pressed it, the small amount, scanty amount came out. So most probably it is a physiological discharge. We divided the discharge into two categories: pathological and physiological. The pathological is one when there is a pathology in the ductal system itself. Otherwise, when the ductal system of the breast is absolutely normal, there is no pathology, then it is categorized in the physiological category. So nipple discharge, by definition, it is the when secretions are abundant or persistent enough to discharge spontaneously from the duct orifice. It is known as a nipple discharge. Persistent means it should be more than twice per week or more frequent than that. So basically, because when we pressed, a small amount of fluid came out which was not blood stained, and as such patient was having no complaint of lump in the abdomen or pain in the lump in the breast and pain in the breast. So it is physiological one. And basically breast is an apocrine gland, we all know. It is a modified apocrine gland. So this discharge is most probably because of that, that condition.
Very nicely said, Dr. Chelly. Do you have any other opinion, Dr. Radhika? Dr. Radhika from Dehradun, are you there?
Yes, ma'am, I'm here. Am I audible?
Yeah, you are very well audible.
Yes, everyone. Ma'am, सबसे पहली चीज I'd like to emphasize upon that every time a female comes to us, we must examine the breast. Usually nipple discharge is given importance अगर spontaneous complaint ही हो patient की, but कई बार especially perimenopausal ladies or some people above 40, females above 40, breast examination जरूर होना चाहिए, proper clinical history होनी चाहिए. कभी कभी discharge निकल जाता है, कभी कभी perimenopausal में भी बहुत common होता है, but ये differentiate करना और patient को reassure करना कि physiological है या pathological है, this must be done thoroughly, ma'am. And
very rightly said. It should be, it should be spontaneous. As in the definition, you see that it should be spontaneous. On pressing, if the discharge is there, this is not told to be nipple discharge, because many times on pressing, the discharge is there. Of course, you have to assure and reassure your patient. In this, these are the apocrine secretion. As breast is a modified apocrine gland, as told by Dr. Shelly also. So many times it is seen after warm bath or after pregnancy or after the nipple manipulation. So no specific treatment is required in this case. So proceeding to the second case.
May I say something?
Yeah, Dr. Taru, please, your comments.
See, once a patient has seen some discharges coming out of the breast bag, whether at the time of our examination, the patient gets tensed. So we have already counseled them, as Dr. Nikat has said, we have already counseled, but we have to tell them repeatedly they will not do this at home. They should not do it. Otherwise, it will increase the discharge and they will get tensed.
Right.
Very right. And you have to elaborate the conditions in which normally this is there, but you need to follow it. Follow it, and of course, they must do self-examination, self-breast examination. They should be properly trained that it is not associated with any lump or any other pathological condition. That is important.
Dr. Kanchan, can I say something? I know I'm moderator, but
yeah, Dr. Reshu.
Yeah, Dr. Taru, I totally agree with you, because now once you have examined and now that thing has come, so it is quite apprehensive for the patient कि डॉक्टर साहब ये क्या, मैं तो पेन के साथ आई थी और अब ये डिस्चार्ज भी है. So the current data on clinical breast examination does not recommend, if the patient has not come with the complaint of discharge, like this patient, she has just come with the complaint of pain in breast. So when we do clinical breast examination, the technique which with 4 flat hands, and we are supposed to either clockwise or whatever technique each person use, and we keep on increasing our pressure, mild, moderate and severe. But the pressing of nipple areolar complex is now no more recommended, because this is a physiological thing, and because of this condition, this clinical breast examination, now routine pressing of nipple areolar complex is no more recommended.
Of course. Yeah. Any other opinion? Dr. Nikhat is there? Dr. Nikhat from Srinagar? I've seen she has logged in.
Yeah. Can you hear me?
Yeah, very good. Welcome. In spite of all the
but I'm trying my best, but it's switching off right now because the light is coming and going. Aa rahi hai, ja rahi hai. So I'm trying my best to hold on to it.
Thank you.
But
We need your comments.
Yeah, let us so. No, as far as this first case is concerned, one is, I mean, to be frank enough, one cannot 100% be sure whether it's pathological or physiological, because you never know. With a minor complaint also, it may be because as of the breast awareness we are going on, and we see breast CA is on a rise. And then one has to, like unilaterality, is it in the one breast or both the breasts, then with the duration, and these things have to be, the history has to be little elaborate. But as far as the patient, this case is concerned, it probably is not something sinister, and we can just wait and watch, and no medication as such is needed.
Very right. A very strict follow-up is needed, and we are coming in the coming slides. What are the differences between physiological and the pathological discharge, and how to differentiate and how to follow these cases? Thank you for your comments.
Thank you.
Now, should we come on the second case? A 32 years old unmarried lady working as the manager of the big company. She had a hypothyroidism and was on Eltroxin 75 microgram since last 2 years, and she was also taking anxiolytics, and off since last 6 months. She presented with a complaint of watery discharge per both the nipples on and off. Since last 1 month, she was having watery discharge, and the discharge is variable in amount. At the time, little milky. It was a little milky at times. There was history of associated retroareolar pain and no history of any palpable lump, because she used to hear and does her BSc regularly. Her menstrual period were very regular. There was a history of CA breast in maternal aunt at 50 years of the age. There is no history of the surgery. So my question again to Dr. Nikhat. Ma'am, what history will you elicit in the patient presenting with a nipple discharge in this case? Especially, how will you proceed in this case?
First of all, as you said, from your history, there is history of drugs like hypothyroid. She is taking drugs, and probably first, I think in this part of our place, I have seen number of patients coming with galactoria and a discharge, and the history of PPIs. Because self-medication is so rampant that people, for any esophagitis or for any gastric problem, they are taking Pentop, Domperidone, and other. And I have seen that patients come with galactoria. Once you stop them, you do their prolactin level, and they're very high. And once you stop this drug, they become fit and fine. So that is, drug history is very important. Secondly, the history is suggestive that there is a close relation with had a breast CA, so one has to be careful regarding that. But at the same time, it is bilateral. So if it is bilateral, then it's not usually when we see breast malignancies. If it is from both the sides, if it's from one side, then you become more conscious that it may be a malignancy. And as far as the type of discharge, watery discharge, you said probably watery discharge.
Watery discharge, sometimes milky. Yeah.
Sometimes milky. So
Yeah,
as far as the drug history is going, drugs can be one of the culprits, as I told you, PPIs. And this history, as from my experience, young girls coming with the allochtoria, middle-aged, reproductive age, you elicit the history and you have to be. Then how long has it been there? If it's something chronic, if it's a chronic thing, then you at least are safe that it's not something sinister, because if going there for a long time. And then what was her marital history like? Or
unmarried. I have mentioned it.
She's
32 years,
unmarried.
unmarried girl. Yeah.
Oh, okay, unmarried girl. Then, of course, we have to have rule out metabolic syndromes also, because there's a correlation between all these. And as far as I would suggest, I would just like to know the duration. I would know
1 month it is mentioned.
chronicity,
It is mentioned.
chronicity, and then of course drug history. And then of course, then beyond that, self-examination and investigations have to be started.
So very well taken all the points. History of medication, the family history, as her maternal aunt was having history of CA breast, but more towards because physiological, because she is a hypothyroidism patient, she is taking anxiolytics, and drug history, maybe they are taking PPI.
Yeah,
Very well.
anxiolytics, yes, yes.
Anxiolytic, because these anxiolytics are one of the main cause which causes increase in prolactin level and increased discharge, galacturia. So how
And
will
also
you
in the
examine?
history, we should also take the history of any trauma or any recent event which was stress, which was giving stress to the patient,
Yeah, there was no history of any
or
trauma.
any history of some chronic illness, ma'am, because in chronic illness like CRF in all things, there also can be the cause of this type of
So
discharge.
Dr. Shelley, how
So
will you examine?
a thorough history is very important, ma'am.
Yeah.
Yes, ma'am.
So Dr. Shelley, how will you examine?
On
Can I add a
examination,
point here?
Dr. Pawanpreet, yeah, please.
Ma'am, in history, drug history, we talked about all the things, though this doesn't apply to this case because she is unmarried, but still a history of oral contraceptives is also very important.
Yes.
That is one very common cause for increased normal physiological discharge from the nipples.
Very rightly.
Sometimes
very rightly.
associated with a high prolactin level, and sometimes with a normal prolactin level also we see physiological discharge or sometimes galacturia in patients on oral contraceptives.
Very right, very right. Excellent point. So in history, we should take whether this is a spontaneous or induced, unilateral or bilateral, appearance, color of nipple discharge, frequency, as we have seen, the amount, whether this is a copious or a scanty discharge, history of trauma, as Shelley was saying, history of amenorrhea, sometimes in galacturia also, because of disturbance in hormonal level, there is amenorrhea, history of any chronic illness or medication history, and she is taking these, all the points are there which are to be elicited in history. Very wonderful panel.
One more thing, ma'am, in case there is no other history of anxiety or stress or any drug intake, I've seen many cases when prolactin comes as a neighbor of TSH.
Yeah.
Because she is taking Eltroxin, so she is
Yeah.
hypothyroid, so maybe a little prolactin is high and she is giving a complaint of galacturia.
So these type of patients need assurance, reassurance, and follow.
Yes.
And one more thing I would like to say, because one of the panelists said that oral contraceptives, because nowadays young girls, PCOD has become very rampant, and one of the PCOS is very rampant, and OCs have been implicated in the treatment. So one has to elucidate that history.
I'd just like to add a point
History,
that
very important.
Dr. Radhika,
mentioned in the history that her maternal aunt had a history of breast cancer. It should be emphasized and it should be explained that even second degree relatives, especially the female, obviously the relatives, if there is a history of cancer, she must undergo regular yearly checkups, gynae follow-ups, and if required, a mammography or
possible
follow-up.
BRCA test if possible, ma'am.
Right.
Yeah,
Right, BRCA test because it is a genetic testing that is needed in these cases, and close eye on the patient.
Right.
Very rightly said. And how will you examine the patient with the nipple discharge? What are the important points in examination, Dr. Taru?
Yeah, in the proper position, in sitting position, and all relaxed condition, we'll examine the breast and we squeeze. There are 2-3 methods to examine the nipple. One is the squeeze method. So that turns out better because it will not harm the capillary ducts. So we see whether what type of discharge is coming out. Thoroughly, we examine with 2 fingers. We'll examine the breast as well to rule out any lump inside, or with that we comes to know about the tenderness if she complains while examination.
Yeah, very rightly said.
And axilla both should be examined.
Yeah,
Exactly.
lymph nodes, we have to report axillas also. We have to rule out lymph nodes. If the axilla may be, we can see also.
Also,
I
while
think
we are
it's very
examining the
important.
patient with the nipple discharge, we should also examine whether it is unilateral or bilateral. And in unilateral also, whether it's coming from a
Unilateral and
single duct
bilateral.
or multiple ducts it is coming, because
Yes.
uniductal pathologies are more
In examination में तो
severe.
दोनों breast को ही examine करना ही चाहिए.
And breast पे भी मैम कि वो discharge एक duct से आ रहा है कि side duct से आ रहा है, ये भी आपको देखना है इस टाइम पे.
नहीं, और
And then जो discharge
It
आता है,
is sometimes recommended to use a
consistency.
magnifying glass to see whether it is coming from a single duct or multiple ducts. That can be quite
This is
helpful.
a great idea. You should use a magnifying glass and see discharge is coming from single duct or
Single duct
multiple.
or multiple. That's how you can do it. You need a very good light and some sort of magnification.
Magnification. Very right. Any other point from any other
Nipple
panelist?
retraction, nipple retraction is also to be seen. Sometimes the first sign of malignancy, they have a retracted nipple. That is very important to
Yeah.
see on the shape of the nipple
Everyone
and the
follows
retraction of the nipple.
general headings of inspection, palpation. So I think all of them, we
Yes.
cover them very well. It's difficult to put together on a platform like this, but we're all routinely doing our, the best we can. And of course, talking to the patient and reassuring.
Yes, yes.
Yeah. So very well said that you should look whether the duct system is normal or abnormal. If it is abnormal anyway, there is a pathological discharge. Now coming on, what are the differences between the physiological and pathological nipple discharge? Dr. Radhika, will you mention all the features, differentiating point?
Yes, ma'am. Ma'am, जब भी हम discharges की बात करते हैं, it can be physiological, it can be pathological. When we consider a physiological discharge, usually it is bilateral. Usually it is from, it can vary in color from white, from, even greenish color or even a brownish color. The greenish color being attributed because of the cholesterol deposits. It is usually, the causes are manual compression or any sort of, there can be a history of trauma sometimes in a case of a physiological discharge. Otherwise, a certain amount of stress. And even in some perimenopausal ladies, it can be just normal also, but would require follow-up and attention. And pathological discharge may usually unilateral hoga. The color may vary. It will be heme occult, blood positive hamesha usually aata hai in a pathological discharge. Also, pathological discharges will have certain pathology involved. या तो कहीं आपको lump मिलेगा या आपको duct से आपको जो देख रहा होगा, that will involve probably multiple or a single duct. And usually it's seen in cases of ductal papillomas or ductal carcinoma in situ or a ductectasia or frank cancer, which I feel if it has reached that stage, there will be other visible symptoms of the skin or retraction along with it.
Very true. Very true.
Very well said. There is a clear-cut difference between the pathological and physiological. Very well illustrated. Any other point to be added by any other panelist? All covered. Okay.
I would like to add one point
Shape
here.
of the breast. Shape of the she is already said. Shape of the breast, nipple retraction, slide, one-sided or generalized, and some case of abnormality in nipple, That's very important to explain and counsel the patient as well.
Ma'am, one point I would like to add here about some pathological discharges. One discharge which is always pathological, though it is not very pertinent to our discussion because we deal with females. Any nipple discharge in any male patient, whether young or old, is always pathological. That has to be taken seriously and investigated. That is one point.
That is a male, very brilliant panelist.
For that matter, madam, I think any breast abnormality in a male, whatever it is, symptom may be any, be it lump, be it
has to be taken. Yes.
Be it has to be considered always pathological. And first differential is always malignancy, and then you think about the rest of the differences.
Absolutely. So, Dr. Taru, will you enumerate the etiology of the physiological nipple discharge? What are the types different?
Yeah. Physiological nipple discharge, it is different varieties. It can be because of neurogenic stimulation, can be because of sleep. We sleep in abnormal position of sleep. It presses the breast. When some exercises, we are doing extra breast press exercises and excessive stimulation while in sex also, and midday proteins. But there are physiological discharge due to medication we discussed earlier also, hormones, antidepressants, anxiolytics, estrogen receptor antagonists, phenothiazines, and amphetamines. Antiemetic like domperidone is mainly responsible for this. Danazol, INH, opiates, and antifungal. Antifungal I have not seen because it's written here, I'm saying, but I don't know seriously about this. Antifungal can cause physiological discharge. And medical and surgical conditions like pituitary adenomas, hypothyroidism, herpes zoster, because in such conditions our immune system is reduced and other conditions can flare up, and bronchogenic carcinoma, end-stage renal disease, and chronic liver disease.
So very
associated nipple discharge can be.
All the causes. Any addition, Dr. Nikhat?
I think she has touched everything. And as far as we were talking of the size of the breast, enlargement of that can also give a clue to pathology. If the breast is there's a difference in the size of the breast, that could be pathological. Except that if the mother, if she's
initially it was normal and now it has become this change without lactation.
Yeah.
So that we have discussed what are the differences between physiological and the pathological.
Anybody has
Any
seen
addition, doctor?
medicine given and there is discharge?
Yeah.
No. Not me.
What?
Antifungal dene pe breast discharge, ma'am. Has anyone seen?
That is mentioned in the literature that the few of the antifungal, if you give for long, that is in the literature that causes.
Actually, we do not use that much amount in that duration.
Yes, we don't use it.
It is used by the skin specialist for a prolonged course. Antifungal they give in the high doses. So in that case, it is seen. It is reported in the literature. But as far as we are concerned, we give a minimum dose.
Practically, we have not seen
we give it a short duration course. So we have not seen it. It is reported in the literature.
Okay.
So Dr. Pawanpreet, this is okay? Should
yes,
we
ma'am. Yes, ma'am.
So, as we see, the discharge may be clear, may be bloody, may be brown, may be green, may be yellow, may be milky, and indicate different type of secretions. So, should we move to case number 3? Case number 3, a 36-year-old lady suffering from the primary infertility. Again, a case of primary infertility and is divorced now, with a history of depression and antidepressant since last 5 years. History of hypothyroidism controlled on 50 microgram thyroxine and diabetes mellitus since last 2 years. Presented with the complaint of copious milk discharge per both the nipple since last 6 months. Now complain of a tender lump in the right breast. Very important, tender lump in the right breast with a decrease in the amount of discharge. Patient also give history of amenorrhea, again very important point, since last 3 months. Family history, nothing significant. Surgical history, nil. On examination, ECOG 0, no SCLN, bilateral breast and NAC normal, copious milky nipple discharge, positive from multiple ducts of both the nipples, a lump of about 3 × 3 centimeter palpable in right breast. At 3 o'clock, starting from NAC, the nipple is mildly tender. On pressing the lump, large amount of milky discharge come out from nipple. And bilateral examination, axilla, no axillary lymphadenopathy was. So what is the most probable diagnosis and how will you further manage this case, Dr. Radhika?
Ma'am, first the very fact कि जब she's given us this history complaint of breast discharge, the initial conversation that we must have with her, we must elicit a proper clinical history of asking her about the onset, asking her about the duration, asking her about any medical history, any intake of drugs that she gives while we are proceeding to the examination table. Once we examine her, we definitely see that there is frank milky discharge, and we would like to label it as frank galactorrhea because she's been on the basic investigation whenever a patient comes to us with breast discharge. Since she is a divorcee, I would still like to ask her about any sexual contact as well she's had. And I would also like to screen her through for basic thyroid, for basic prolactin and the beta HCG definitely. Even if she is not able to give me a proper history, we would still put beta HCG in a differential diagnosis. And depending on the reports, what we get, whether beta HCG is positive, if she is pregnant, then we have the cause. If prolactin is increased, then definitely we will think of hyperprolactinemia. And depending on the levels, we may want to do an MRI, we may not want to do an MRI, depending on the symptoms of keeping her on the follow-up. And if thyroid comes out to be positive or negative, we accordingly treat it. So definitely, it'll be a frank galactorrhea, ma'am. And sometimes it can just happen spontaneously also. But here we clearly have history of thyroid medication intake. We have a history of antidepressants. So most likely, this is the cause, which is causing galactorrhea induced by hyperprolactinemia, most likely. But beta HCG must be done in today's scenario. It will save us also medico-legally, I feel, because sometimes patients don't give us proper history and then we don't have the proper results. That's why.
And of course, I would like to say that the amenorrhea, and this has to be, how long has 3 months amenorrhea and when did this start? So we have to correlate the two.
6 months.
5 years.
So much discrepancy in the hormones, that must have been leading to her amenorrhea also, apart from pregnancy, which has to be ruled out.
Milky discharge is for last 6 months and amenorrhea is only 3 months.
That's very important to know from the history.
Right.
Which one is first? The milky discharge is 6 months, amenorrhea is 3 months. So you need to correlate the two because there are so many syndromes and so many adenomas and other things. So prolactin is not only giving galactorrhea, but it can be raised in many other conditions also. So amenorrhea has to be, it is, as you rightly said, that sexual history and of course beta HCG and even ultrasound.
Yes,
ultrasound.
Very right, because now ultrasound is very
important
to us.
Yeah.
So
no,
we do
for the lump
ultrasound.
as well as for a pelvic ultrasound. You know the status of the ovaries as well as you know the status of pregnancy, because maybe medico-legally also, like you said, and you will not be able to talk. She is a divorcee and you may not be, maybe she'll get offended if you talk like that. And if she is educated enough and you do her beta HCG, still she suspects. So just go for an ultrasound. Go for an ultrasound, and not only will it give you whether she is pregnant, it will give you some other pelvic, information also.
So all the possible diagnosis that goes in the favor of galactorrhea. Any other comment, Dr. Pawanpreet?
Ma'am, I feel that's all. And just because there was a lump, ultrasound should not be missed.
Yes, very right, very right. And now coming on the galactorrhea, Dr. Shelly, will you say what is galactorrhea? Shelly Agrawal.
Yes, ma'am. Galactorrhea is basically the breast milk discharge from the breast outside the pregnancy or childbirth. By definition, it is the galactorrhea. So we have many causes of this galactorrhea. Maybe some reason in the pituitary itself, maybe due to some medications, maybe some stress related. So there is the discharge from the breast, which is spontaneous, and it is milky in the color, white in the color, and milky in the consistency. So these all constitute the galactorrhea, and there's a long list of the drugs which can cause the galactorrhea. And pituitary adenomas, microadenomas, and
macroadenomas to be
macroadenoma, and see the prolactin level.
A thorough investigation should be done on all these cases regarding the hormone profile, especially the thyroid hormone should be checked, because in hypothyroidism there can be increase in the prolactin. So we have to rule out the hypothyroidism and then prolactin level. And then if it is the more than 100 prolactin level, then we have to go for the scanning of the brain to rule out any adenoma in the pituitary itself.
And
Yes,
you
we
have
may
to
need
see
to
about
have
the
a-
symptoms of the galactorrhea also.
Yes, ma'am. And yes.
They
And
are
it's- if you- pituitary adenoma, there will be some visual complaints. Patient may have some visual problems also. So we should elicit in the history itself.
Headache and irregular
Headache
movements.
and vision problem. Yes.
We may need to have a consultation. I mean, because in these times when we are so, documentation and medical legal aspects are there, you may have to have a consultation with the neurologist also, because microadenomas and macroadenomas, and whether benign, malignant pathologies, we have to take sometimes into consideration, have a consultation with the neurologist also.
Definitely, if
Endocrinologist.
we will see a pathology, the lesion in the
Endocrinologist
MRI,
will be
we
more-
should
Yeah.
refer the patient to an endocrinologist or some
Yeah.
neurophysician also.
Neuro.
वो तो shoulder sharing है ma'am.
Yes, yes, definitely.
So, Dr. Radhika, will you throw some
Gynecologists
light on the
don't
evaluation
leave
of
anyone
galactorrhea?
alone. I think we always like to, refer to so-and-so, refer to so-and-so. We are always, I think since our PG time, we are grilled into taking the whole team with us.
No.
and
Make
not
your point first. Make your concern. Don't before
No,
she
of
says
course,
galactorrhea.
of course.
I mean,
No.
this is out of way discussion. So before make a consensus. What is your probable diagnosis? What is your probable this thing? What can be the differential diagnosis? And then make yourself wiser.
Approach. Definitely, I would say the same. Certain amount of defensive practice has to be done because there are times you're so busy in the OPD, you may be in a different state of mind. You may have somebody in labor. You're doing a simultaneous OPD, so it is always better to pen down things.
I mean to say we don't need to focus just on one point, because it can be very like I can say a gastroenterologist. A patient gives a history of bleeding PR. He just thrusts on endoscopy and colonoscopy, not going here and there, right? And then many times we miss the diagnosis, and I have practically seen it. Not
Ji.
putting a hand on the abdomen, not doing an ultrasound, and missed a very big mass. This
Absolutely
recently
right.
happened.
We
Because
have
the
basic homework very well.
focus was on her hemoglobin is less, and focus was that she had some blood with stool. So he
Right.
jumped onto endoscopy, not doing sonography, when after a lot of time, a big mass was found in the abdomen. So one has to take the patient in toto. That's
Yes,
what.
yes, that is important.
Very
Many
right.
times we have seen the cases, patient is being referred from private practitioners. She is having bleeding period. Patient is on hormone therapy and all. But when we do a PS, we see a mass in the cervix, or so these are missed if you are not seeing.
So very right. First of all,
evaluation is very important in each and every case.
Clinical examination, very important. Leave gadgetry alone. Leave these
Agreed.
gadgets last. They should be the second. Clinical examination must.
Yes.
Very, very right.
It is your
Brilliant
best friend.
discussion.
The CS has
And
to be done, CS and PV.
yeah,
Pardon?
first of all, the
I
patient
said
should
the
be examined
speculum is
as
our
a
best
toto.
friend. We have to do it.
Toto.
Toto. Very
Very
important,
correct.
and don't miss. And it is better to involve other specialty person also. If you are busy in your clinic, it's a better suggestion.
I'll practically also say that when somebody complains of breast complaint, you just focus on the breast. Just try to touch her tummy also. Just try.
Precisely.
पूरा एक हाथ लगा के देख लो आगे पीछे कोई और स्वेलिंग तो नहीं है, बिकॉज वो इतने फोकस्ड होते हैं ब्रेस्ट पे एंड इतना डर है आजकल, तो वो you can miss, you can say
Dr.
miss that.
Kanchan, can I leave? There is some emergency.
Sure, because this is too late. No?
Yeah, it's too late
Thank
now.
you
It's
so
too
much.
late.
So
Thank you so much.
evaluation of galactoria,
Can
I
we
think
hurry on
we
the
should
other?
omit. Pituitary adenoma may be a cause.
We can go to the other two cases hurriedly.
Other two cases, Dr. Reshu Agarwal will be taking other two cases. So I give Dr. Reshu Agarwal hurriedly finish the other two cases. Dr. Reshu, are you there?
Ma'am is there. Ma'am, आप mute हैं.
बहुत टाइम हो गया ना, बहुत टाइम.
Dr. Kanchan, can I use my screen share?
Yeah.
So
I'll
you
stop
can
sharing
exit
and
yours.
yeah. I'll stop sharing. एक पिक्चर तो ले लेते हैं सबकी प्रिंट स्क्रीन with a brilliant panelist. I have taken a screenshot. We'll be sending you all.
Thank you.
My pleasure.
Thank you.
Thank you, ma'am.
And thanks to my electricity, I don't know how it.
Our all good wishes.
And my connection is also very unstable because सारा मेरा data use हो गया, बच्चों को hotspot लेके बैठी हूँ मैं अब.
Dr. Reshu, जल्दी से करिए.
बच्चे hotspot दे रहे हैं अब.
Thank you once again, Dr. Kanchan Sharma, for giving me the opportunity for this panel. I am breast and gynec oncosurgeon. So I'll be just quickly, I'll not waste much time. What is your opinion?
Illustrate your CV also, Dr. Reshu.
So, thank you, ma'am.
CV कर दें क्या? CV and bouquet to you.
No, ma'am. Please, we'll finish the cases.
Breast surgeon. One and only.
She is a very brilliant and efficient breast and oncosurgeon, uterine cancer surgeon in our city, and very good knowledge.
And very helpful also.
And she is very helpful always. And in further breast series also, we are involving her. Welcome, Dr. Reshu. There is a bouquet, virtual bouquet for you also. Please come and take the other panel questions.
Should I start?
Yeah, sure.
Yeah. So this is a 23-year-old unmarried, regularly menstruating girl with no known comorbidities and with no history of taking any regular medications, presented with complaint of watery discharge per left nipple since last 3 months. No history of any discharge from the opposite nipple, no history of any lump in the left breast or the either breast, no history of any axillary lump, no history of any trauma. Family history, there is no history of any malignancy and there is no history of any surgery. I examined her. She is PCOG 0. She's thin-built girl, no supraclavicular lymph node palpable, and left breast, breast and NSE was normal. There was copious watery nipple discharge present from the duct at 3 o'clock. Rest of the breast was normal, no palpable lump, no axillary lymph node pathology. Opposite breast also normal. So I would like to ask Dr. Shelley, how will you further investigate this case? What differential are you keeping in mind? And how will you proceed in this case?
First of all, it is a watery discharge which is unilateral. So there must be some pathology. So it is not a physiological one, it should be a pathological one. First possibility comes to my mind. But as such, there is no lump palpable which we could palpate. But this patient needs a thorough workup because, so in this case, we have to go for the ultrasound of the breast. Basically, a sonomammogram should be obtained. And then if needed, if we find some lesion on the ultrasound, then we can go for the mammography also. And this the secretion which is coming out, it should be sent for the cytology itself. And if we could find a lesion on the ultrasound or on the mammography, then we can go for the FNAC or biopsy, depending on that. And sometimes, if though no lesion could be found on these things, then we can go for some sophisticated investigations like contrast enhanced MRI and so on.
Dr. Nikhat, would you like to add something? Have we missed anything in history?
No, I would just like to say that if it's a Kupis discharge, watery, the cytology would be the first thing. So you don't need to do a needle and put it, just take the material for cytology. That would be the first thing. And then, of course, ultrasound being non-invasive, those would be the two things. So they can complement each other. So a lump there, a cytology, an ultrasound. After that, I think we can move on to MRI and other things, because you can't order all the things at one time.
Yes,
That's what.
So very well said. We have to first make our algorithm, and chronologically we should do test rather than writing all the tests at once.
Yeah, because instead of doing an FNAC, this fluid will tell us. Then if FNAC doesn't tell, then we'll have to go for core biopsy, which is a more advanced. And then ultrasound breast is this cytology, and this will complement each other. So at least we can come to. Then there's clinically also there is a lump. So that
and there is no lump.
Oh, sorry, there's no lump. And then the ultrasound will also tell us about the density and the other structural outcome the breast. So I think these two will complement each other, and then we can proceed on to the other.
So, ma'am, Dr. Shaily and Dr. Nikhat, as you have very well pointed out, these are the battery of tests available with us. Ma'am, this is Dr. Radhika. This is watery discharge. She's a young girl, although unilateral and coming from a single duct. Would you like to still do some hormones or no?
Definitely, yes. I would definitely like to do a prolactin. I would definitely like to do a baseline thyroid, even a basic CBC to rule out any infection. Sometimes leukocyte count also increase. And again, I would emphasize, without being judgmental, that sexual history should always be taken, because I think we're in times where these questions are very important, put of course in a very polite manner. So if there is any history of sexual interaction, I would probably then go in for a beta HCG. But thyroid and prolactin and a CBC, definitely, ma'am. And even in the ultrasound pelvis, like ma'am Nikhat ma'am had earlier said, that sometimes, there are variable parameters on which PCOD exhibits its symptoms. So definitely a baseline scan to check for the ovaries, the uterus.
So, Dr. Pavanpreet, is she here?
Yeah, ma'am, I'm here.
Dr. Pavanpreet, as all the panelists have very well said, so Dr. Nikhat has very well pointed out that, all the battery of tests should not be written together. So like this patient has entered to the OPD. So what will be your first set of battery which you will write on her prescription?
First would be cytology, because we are getting fluid secretion is there. We can send it for the cytology itself.
Yes, ma'am. Ma'am, since she's a young girl, my first battery of tests would be thyroid, prolactin, a UPT, and ultrasound breast, and cytology, and occult blood test might also be needed because it's unilateral. Coming from a single duct, unilateral, I would like to do occult blood test also.
So these are the battery of investigations available apart from blood labs, which we all know very well and we have discussed in previous case. So pertaining to breast, we can go for ultrasound, mammography, nipple discharge, cytology, FNAC, contrast enhanced MRI, biopsy. And there are some interductal approaches, out of which ductography is very common. And there are two others. Ductography is routinely done by the breast specialist. And ductal lavage and ductoscopy is something which is under clinical trials. It has not been put into, for this thing, but it is under investigations. So just coming on to I'll just rush off. Ultrasound is always a non-invasive and not very costly test. So we go for it. And if there is ductal system abnormalities like dilatation or there is internal wall thickening, or any associated lump which is not palpable, ultrasound very well shows it. And it is important aid for performing USG guided core biopsy or FNAC. But limitations are that in case if there is no small lesion or there is no duct dilatation, or the breasts are very dense and fatty, it has limitation in visualization. And of course, it is very much operator expertise dependent. I have seen many a times the radiologist, although they are very good in their work, but if they are not doing much of breast ultrasound, so their expertise decline in doing breast. Similarly, mammography, it is a standard imaging technique. After 40, we say, but now we are coming because young age CA breast is increasing. So we are coming down to 30.
Right.
And microcalcifications and other features which are suggestive of malignancy can be seen. And but mammography is not very useful for the diagnosis of etiology of ND. It can tell you the features, but it cannot tell you that why the nipple discharge is. And for malignancy, it has a very high negative predictive value and specificity of 94%. Coming on to ND cytology, it is simple but controversial. Why it is controversial? You can have a look at the data that sensitivity is 16.7 and specificity is 66% for any ND. And if it is blood stain, it improves to sensitivity improves to 60.6 and specificity 53.6. And few studies report as high as 85 and 90. So there is a lot of variability in lot of studies. Some saying as low as 16.7 and others are saying as high as 85. But simple, non-invasive, not very costly. And in my opinion, it should be done in all in cases, at least with occult etiology. FNAC quite sensitive. If you find something in ultrasound or anything, and if the cytology is less, the discharge is very less, and you cannot take enough sample, then of course FNAC. But it again has limitation. False negative rate is as high as 10 to 15%. And whenever you are discordant, there is discordance between FNAC and imaging, then we have to go for core needle biopsy. It has inability to test for breast cancer subtypes, and again it is cytopathology skill dependent. So what we did in this case, I'll come to that. We did ND cytology, and it was intraductal papillary lesion. We did ultrasound breast and axilla. It was a 0.3 centimeter cystic lesion in subareolar region at the rate of 3 o'clock. And we did FNAC from that cystic lesion. It was benign papillary lesion. Hormonal profile and the labs were normal. So now what treatment will you offer to the patient? Anybody can take this question.
I think definitely, ma'am, a mammillary
This patient will be referred to a breast surgeon, ma'am.
Yeah, I mean, that is very easy, ma'am. You will send her across to me. And she was also sent to me by a very renowned gynecologist of Kanpur. But still, we are just discussing. So
I think a mammary ductoscopy, and it may be assisted with a microdocectomy, probably.
So how many people really do ductoscopy? How many radiologists?
Very few.
So
very few, I think.
I think I know nobody. From Kashmir to Kerala, so I don't know anybody, but I don't know about others. I mean,
no, and especially for I think I'm from a very small town, so I think the basic.
So we always should talk about small town. Big towns can do anything,
Yeah.
So small town ductoscopy is something like
not done.
So not done.
Yeah, not done.
Microdocectomy. So can we observe this patient? Can we leave her for observation?
I would suggest, and I would say no. If it has, it's not turned into features of any malignancy, but definitely it can be a potential source of turning into malignant. So therefore, it should be removed. Definitely.
The patient is very compliant. She's willing to be in our follow-up. Then only we can wait and watch, because papilloma are benign lesions usually with a very less percentage of turning
because
into
she is
malignant.
unmarried,
That
so she has
depends on,
convinced her fiance and saying that madam हम तो घर पे बता के नहीं आए हैं, तो क्या ऐसी कोई उसका fiance पूछ रहा है मैडम अगर ऐसे ही छोड़ दें थोड़े दिन तो, so how much comfortable Dr. Pavanpreet you are in leaving?
Ma'am, depends on how long has been the history. If it
So
is
it is
a
3 months history, madam.
Ma'am, I think if the patient is well educated, understands, and can come for follow up, we can observe her for some time and probably give her some symptomatic treatment if we feel there is any need for any antibiotic or any analgesic that can be done, and she can be called for follow up a
But
little
all these
later.
things should be prescribed with caution. See that, okay, you are demanding, so I am doing it.
Yes,
But
yes,
then
yes. Proper documentation.
Yes, proper documentation should be
documentation. That even if I am leaving, it is not my wish. You have
It is
to
the
get
patient's
operated.
wish.
It is your
Patient
wish. You
has
are
been
not-
advised surgery, but is not willing.
Yeah.
At
No, but at the
proper-
same,
Yes.
and they should be properly documented.
Yes,
That is
yes.
what my message is. So I offered her surgery. That is, of course, because she's a young girl. So microdocectomy. Of course, I will do intraoperative ductography in her and do microdocectomy. So this is a simple algorithm. So each institute, or there is no particular, but this I have jotted down that how we, clinic, most of the institute in worldwide manage their patients. So once the patient has come with nipple discharge, just see whether it is single duct or multiple. If it is single duct, yes, of course, for gynecologists, it is like referral to best surgeon and appropriate surgery. Conditions are spontaneous, and one of the characteristics, bloody or blood test on ND is positive, persistent, there is associated lump, and there is new discharge in a woman more than 30 years of age. If it is multiple duct, if the age is less than 30, one can go for observation. But if there is a persistent discharge, then one must offer surgery. 30 to 45 years, either approach. More than 45 years, surgical excision of the major ductal system. I mean, this is not, this is what we practically do. So this lady, what happened, this girl, because I told you that she came with fiance and she said she has not, so she ran away. Now she is again presented to me after 9 months with the same complaint, and she is now saying that now I have told in my home and I am ready for surgery. So will I do the surgery, or will I, what I will do?
That's one point which I wanted to tell you, because somebody was saying that it has to be documented, then tomorrow she'll say, I don't think it is only the documentation part. It is the compliance of the patient. Then you have to put your foot down. If you know she'll be lost to follow up, she'll not, although she may tell you that time that I don't want to go for surgery, will not be lost to follow up. But our primary responsibility is to put our foot down, because now she's coming after 9 months again with something sinister. So if we were that time very much confident, and we could have told her that, well, ये तो ठीक है, आप अपनी मर्जी पर जा रहे हो, but you can't live a life like that, she turns into a malignancy. So उधर आपको देखना है कि compliance है, patient का educational status क्या है, approach to hospital क्या है, economically क्या है, क्योंकि जो बहुत पढ़े लिखे हैं and educated and the compliance, उनके लिए तो it's not, they will definitely, उनमें awareness भी है. So that time now, because you said that she again came after 9 months. So this time, I think one would feel sorry then.
No, ma'am. And one thing which I would like to also, point out, which I have forgotten. See, the ND cytology and FNAC, it is the pathology which has come out on cytopathology is intraductal papillary lesion.
Yeah.
It is not papilloma. So there is a lot of difference between papilloma and papillary lesion. Even if it is no ATP are seen, but papillary lesion and papilloma, these two are very different entities.
Yes, I know. No, I was talking in general. General. Suppose अपने आप को safe रखने के लिए कि हमने इसको बोल दिया, भाई अपनी जिम्मेवारी पे जा रहे हो. But sometimes when you are in doubt, or you may think that she'll potentially going towards she may be a potential malignant patient. So that time we may have to cut a sorry figure. So all these things have to be kept in mind, her educational status, her compliance, her loss to follow up. That was in general for all other patients. This is out of my experience. Huh?
Yes, ma'am. Yes, ma'am. And we should not, just consider on the basis of age that she is just 23. So it might not be like that.
Yes.
Any patient can be anything. And,
Yes.
one has to keep a very low threshold for at least the diagnosis of malignancy.
Right.
So after 9 months, she came, and now she is ready to, Doctor Saab, aap mujhe date de dijiye and I'm ready for the treatment. But then doctor said, no, I will re-examine you once again before. So, and the findings were same as before, except that now the discharge is little serosanguinous. It is not completely watery or clean. So what will be the change of management, or will the management will remain same, whatever we have decided?
I think we will put her in a high risk category, definitely, because the color of the discharge has changed. And in such a case, I think a contrast enhanced MRI will be a better choice of investigation, but it will give us an extent of the disease.
Yeah.
What is the exact status? And then after that, then I think a further planning should be done. Whether a biopsy is required or whether a local excision, depending on the MRI report, is required. But first, definitely, I think a contrast enhanced MRI, ma'am.
Yeah.
Ma'am, I think even before that, we'll need to repeat the cytology once again.
Sure, ma'am. Repeat the cytology also,
Along with
the
it.
ultrasound, all the
That should be,
battery of tests.
that should
Again needs
And
to
clinical, and of course, clinical
clinic.
examination.
Clinical
Huh?
examination.
Clinical
again.
examination.
History taking again
Again,
the
history
same thing.
taking, again history
the-
taking, again examination, and again, and of course related to the general condition, what must have happened all these months.
Because these are, and also the places she has gone and shown herself, all
Yeah.
those
Yeah.
documents also.
Of
Because
course.
patient doesn't sit quiet. They will say
No,
to you,
no,
but
no,
they
no,
don't
no.
sit quiet.
Yes, yes. And definitely she will not come back to you so easily, because you suggested that, so she may go on wandering for other doctors. Ye theek tha, ye theek tha, ye usne galat bola tha, ye sahi bola tha, and then finally she came back to you. That is there.
So, as very well said, that yes, we would like to do now MRI. कि नहीं भैया ऐसे तो नहीं करे वरेंगे, अब पैसा खर्च करो. और अगर बायोप्सी की भी जरूरत पड़ी तो करनी पड़ेगी. So, contrast eminence MRI has a very high sensitivity for picking up the invasive as well as intraductal CA, and it is very useful in differentiating between benign and malignant lesion, and especially in ND with occult disease. So we again repeated everything as you see, and now contrast enhanced MRI showed MR-Reds 4C lesion. So what we did is we did core biopsy from the lesion. It was a 0.3 centimeter lesion only. And now see the change in report. Now it is papillary neoplasm, but with foci of atypical ductal hyperplasia. So this is how the things changed in her. So that is what the role of where biopsy comes, and FNAC fails and biopsy comes into picture. So we have, usually we go for needle biopsies are preferred. Excisional biopsies are result for very few cases. So core stereotactic vacuum assisted biopsies we usually do these days, and excisional is reserved for few cases. So this is core USG graded core needle biopsy, how we do. And its sensitivity and specificity is as high as 85 to 100%, and false negativity rate is less than 1% as compared to FNAC. This is how we go for stereotactic biopsy under TOMO, mammography and TOMO. And these days we are doing a lot of vacuum assisted biopsy also. So after workup, I took her up for surgery after having told that देखो भाई ADH आ गया है और DCIS आ सकता है. तो अगर ये DCIS आ गया तो ये सर्जरी सिर्फ एक डायग्नोस्टिक रह जाएगी, और अगर DCIS नहीं आया तो ठीक है, ट्रीटमेंट है. So we took her up for surgery. And this is what we did. We did intraoperative intraductal cannulation of the pathological drug and duct. We did ductography with methylene blue dye, and microdocectomy with wide local excision of the entire area. And now see, this is the dream or whatever you say, nightmare coming true. She is diagnosed with ductal carcinoma in situ, tumor size 1 into 0.3 into 0.3 centimeter. All margins free, but closest margin is only 0.1 centimeter. So here, this is radiologist, how they do ductography, but we don't have any facility, so I do intraoperative. Coming on to next case, now she is a 45-year-old multiparous perimenopausal lady, again with no known comorbidities, and she now presents with greenish discharge per right nipple on and off since last 2 years. Again, no palpable lump, no nipple retraction, no history of trauma, no history of any medications, chronic medication. But she has a very strong family history of malignancy in her 2 sisters at the age of 50 and ovarian cancer in mother at the age of 60. On examination, right breast and NSE are normal, but there is greenish thick discharge from the nipple, from the duct at 1 o'clock, and there is slight retraction of nipple also present. But rest of the breast was normal, opposite breast was normal, and there is no axillary lymph node. We evaluated her with ND cytology, which was acute on chronic inflammation. She is more than 40. We went for mammography, but it was BI-RADS 0. We did ultrasound breast and axilla. It was suggestive of a dilated duct at the rate of 12 to 1 o'clock position. BI-RADS 2, and although this was, and we went for contrast enhanced MRI, which was MR-RADS 2 showing dilated ducts. So what is the probable diagnosis and how will be the further management? Dr. Shaili Agarwal?
Yes, ma'am. My connection is very unstable. Kab mere awaaz chale jaye, I don't know.
Okay.
Basically, she's a perimenopausal age group patient and she is having present with a discharge, which is greenish in color, I think, greenish. So in this age group, there's a possibility of duct ectasia, which is very much high. Yes. So though it is a benign condition, but sometimes due to superadded infections, inflammation may be there. There's a possibility of abscess formation, then fibrosis, then nipple retraction. So all these courses can happen.
Greenish, as far as the discharge is, as far as, it's not hard and fast rule, but they say that blood and bloodish serosanguinous usually goes for malignancies, and greenish goes for cystic lesions, and it's like that.
Yeah.
So we need to, analyze her overall. We have to keep everything in mind. I think at this age, malignancy would be also, I would, investigate on those lines.
Definitely.
So
45, 50, then there is family history, and then you cannot rely on that greenish discharge in the cystic lesion and reddish discharge the malignant lesion. So keeping in mind the malignant protocol.
Yes, ma'am, very well said. That is why the profile should be complete. Whatever it is, greenish discharge, and maybe we could have stopped at ultrasound. But no, considering her family history, her high-risk features, we should rule out and then we should take the decision.
And we must explain to the patient why are we thinking in terms of discriminate or distinguishing between benign and malignant. कि हम क्यों बार-बार उस point के बारे में सोच रहे हैं, considering the very strong family history and considering that despite of all efforts, breast cancer is still the second most common cause in our country. So we should make all efforts to counsel her कि ऐसा नहीं है कि हमें पैसा मिल रहा है, investigations है या हम करना चाह रहे हैं. Because people have this thought कि आप जाओगे तो हजारों के टेस्ट लिखेंगे ही लिखेंगे. So I think we need to talk and
we have to convince her कि भाई कराने पड़ेंगे. लिखेंगे तो ठीक है, कराने भी पड़ेंगे.
And nowadays even patients are very aware of this entity.
These patients
they come forward कि yes डॉक्टर हम सब करा लेंगे.
हमें कोई लिखे तो हम कराने को तैयार है.
Yes.
हमें कोई prescribe तो करे. So this is management. If it is short term, maybe we can, after doing full workup and having rule out malignancy, we can, observe if it is short term and, give some symptomatic treatment or short course. But if it is long standing, as in this case, it is 2 years history, she should go for surgical excision of major duct and correction of nipple retention. This is the surgery which was done. Intraoperative ductal cannulation with blue dye marking of the pathological area, total ductal excision, and white local excision with nipple eversion correction. So these are the some points for ductectasia. I'll not go into detail. Now this is the last case. I'll just rush off. She is a very old 70-year-old multiparous postmenopausal lady with lot of comorbidities, hypertension, diabetes, and one attack of MI. She was referred to me by a homeopathic practitioner with a complaint of bloody discharge per left nipple on and off since last 5 years. And there is no associated lump, there is no associated retraction of nipple, nothing. And family history and surgical history was nil. So just put on what she did for 5 years. Prior management history, she had number of big file of ultrasound breast, MRI breast, ND cytology, and FNACs multiple, but all were normal, or they were normal. And so patient was tired of allopathic, so she tried homeopathic for 2 years, but again no relief. So now she has come to you. How will you proceed in this case?
You give history of MI in this patient, no?
Yeah.
Is she on
She's
any
a high risk, but MI is now settled.
MI, is she on any anticoagulants?
Yes, ma'am. She's on anticoagulants. She's on all the MI drugs.
MI drugs, all the MI drugs.
All
That
the
is
MI
one point which, because you are saying all her tests, everything is excluding, but
No,
then.
no, the test pertaining to the breast.
Okay.
Test pertaining to the breast, like ultrasound, MRI, nipple discharge cytology, FNAC. Since last 5 years, she has gone to many doctors, and all of them have, started fresh and do. She has come to us. Even we will start fresh. So we'll just keep on doing like this, but no result. And since she was like, but till you will not find the lesion, how will you do it? So everybody is justified. One has to find the
It
lesion.
has to be explained that if she is coming with a positive symptom, and अगर एक साल आपने लिया, आपने उस particular साल में you've done your investigations, and if 1 year of period has crossed and the symptom has not improved, the investigations will still be repeated. At least a basic ultrasound will be required to be done on a yearly basis. Yeah, for a follow up.
वो सब हो गया. अब ये है कि अब ये हमारे पास आ गई है, हमारे पैनल के पास. तो हम क्या करेंगे?
She's come after 2 years. We will definitely put her through a screening. 5 years. We'll definitely put her through a screening ultrasound breast along with mammography, both bilateral breast and axilla. And definitely we would go in for a cytology if the discharge is, it's a visible discharge. We would definitely go in for a nipple discharge cytology as of basic,
So we'll do everything. Whatever line chronology we have kept, we'll follow that. We'll not say कि अच्छा ठीक है हो गया तो ये जो है discount है, सब करेंगे. तो we'll start with mammography.
One more point कि जो 5 साल तक दूसरे डॉक्टर ने काम किया है, उसको
multiple doctors है, पूरा कानपुर है.
But you have to tell कि वो अपनी जगह बिल्कुल सही थे.
ठीक है, हाँ.
That point has to be put across, that what they've done was the basis that you're still alive, you're okay, because they reassured you that nothing is wrong.
Correct. So, but you will you rule out the, either before 5 years or now, whatever it is, will you rule out the possibility of her having being malignancy? Dr. Nikhat? 5 years have gone, no change in, no symptoms have extra कि कोई lump आ गया हो, या कोई metastatic site हो, या कुछ
clinical,
हो.
what does the clinical examination show?
Clinical examination absolutely normal.
Absolutely normal.
Except for the bloody
Except
discharge.
for the
Bloody discharge.
Malignancy कहीं ना कहीं कुछ changes आते हैं मैम. इतना भी मतलब breast is a fast growing.
Has anybody has anybody seen that bloody discharge?
Yeah, ma'am. She was evaluated at many institutes.
Because sometimes it happens at this age, not at this age, but at any age, psychiatrical, illnesses or drugs like that. Maybe she's, but now that you have seen the discharge, then of course one has to be just even after 5 years, I would still keep malignancy in mind.
So before 5 years also this was malignancy. After 5 years also this is malignancy until and proven wrong.
Not it could be a what about warts and papillomas and benign ones?
Yeah, ma'am, anything until we are proven otherwise.
Otherwise.
So we did mammography in her case, and what we saw is this. So one thing which was missing in her workup was mammography. People did ultrasound, people did MRI, people did ND cytology, people did FNAC, but
Did
what
not
was
do
not there
mammography.
was mammography. So now here comes how microcalcification was missed on, MRI, sonography, MRI, all that is. So this is what we saw, and we took her up for biopsy. But which biopsy? So ideally she should have undergone stereotactic biopsy, but we don't have it. So we usko kahan bhejna hai? So what we did is this. We intraoperatively we guided marking of that area which showed surface marking. We injected blue dye, we did excisional biopsy, and then we did specimen mammography to confirm that it is the same area. And this is the pathology. She is ductal carcinoma grade 1, tumor size 0.7 into 0.5, all int matches negative. And she is ERPR positive, HER2 negative, KI 67, 12%. So this is luminal A. So this case, I just kept to give the message, it is not true that breast malignancies are fast growing. I can show you lot of patients with 20 years history, 25 years history, who come with metastatic after 25 years, and the message given to them is कि जिस बीमारी ने तुम्हें 25 साल दिए बिना इलाज कराए, अगर तुम उसका इलाज कराते तो वो तुम्हें अमर बना देती, वही बीमारी. So that is why I just kept this case. So these are few slides in pregnancy, just from the point of view of gynecology. Blood discharge in bloody nipple discharge in pregnancy is a common condition. Almost 20% of women experiences due to hypervascularity of developing breast tissue. They are usually benign and they settle quickly. But if they persist, they require treatment. So these are the few causes during pregnancy. To summarize, as Dr. Nikhat has very well pointed out, take detailed history, do detailed examination. Choice and chronology of investigations plays very important role in establishing the diagnosis. Choice of investigation should be based on case requirement, cost, feasibility, and the performance of the test. Always keep low threshold for the possibility of malignancy and timely referral of a case to breast specialist. My take-home message, keep in mind, act accordingly. Don't jump to diagnosis immediately, timely referral. Thank you, ma'am. I'll keep on working like B. And
Thank you so much.
Thank you.
Brilliant panel.
Thank
Thank
you
you so much.
Wonderful panel discussion and wonderful panelist. I think so exhaustive, and we all have even given at times of our clinics and all, because everybody was enjoying, and this was a vast and elaborate discussion and very wonderful discussion with all of you. New introduction and very knowledgeable. Dr. Radhika gave excellent, Dr. Nikhat, excellent and very, very knowledgeable inputs. Dr. Pawanpreet, what to say about you? Very intelligent answer. Dr. Aarti.
I think we had very cool panelists. सब बड़े cool, calm, बहुत giving a lot of expertises. I think it was really great. It was a thorough panel, really. And thank you,
Dr.
Kanchan
Reshu.
ma'am and ma'am. You've been excellent moderators. Thank you so much.
Reshu did a wonderful. सबको बांध के रखा बिल्कुल as a panel, and thanks to our Dr. Usha Goenka, President, who have given a chance to work. Now the vote of thanks by Dr. Seema Dwivedi hurriedly, and Thank you so much
Dr.
for well
Kanchan.
conducting.
Thank you.
Yeah.
Yeah, congratulations. Very good webinar. And sorry, the evening was so hectic. I could not switch on my video because, you know, there was a lot of pressure to finish my work. But excellent webinar, and my headphones were on. Congratulations once again.
Thank you so much. Even being so busy,
Hello.
that was all thing was so interesting to interact with such a brilliant panelist and all very good inputs and good interactions after a long time. So we all enjoyed, and thanks to you that you were still there on the panel even by your earphone. Thank you
Yeah,
so
so I thought
much,
I'll sit,
Dr. Seema.
congratulate you.
Thank
Okay.
you. Thank you. We'll be needing.
Thank you, moderators and such knowledgeable panelists for a wonderful panel discussion. I thank Dr. Usha Goenka ma'am and Dr. Kanchan Sharma ma'am for making me a part of this wonderful webinar. सितारों की महफिल को सजा, सितारों को महफिल में सजा हमने आकाश में गंगा बहाई है और आप सबके भागीरथी प्रयास से ये गंगा धरा पर उतर आई है. So I thank the constellation of stars consisting of the dignified dignitaries who have adorned this webinar with their magnificent and graceful presence. I thank from the depths of my heart Chief Guest Dr. Meera Agnihotri ma'am, Dr. Madhuri Patel ma'am, and guest of honors Dr. Kavita Bagpat and Dr. Sneha Bhuyar ma'am and all the chairpersons for taking out their precious time and blessing us with their words of wisdom and vital experiences of life. I thank the knowledgeable speakers, Dr. Kanchan Sharma ma'am and Dr. Kiran Pandey ma'am, for enlightening us on very important issues of optimizing breastfeeding and dispelling myths regarding it, and emphasizing that breast milk is nature's liquid gold, a gift more precious than anything sold. Some say it forms a bond like no other of connection and trust between baby and mother. Some say it's unique and cannot be matched, its secrets imparted when baby is lashed. Maybe it's a little of all of the above, but I like to say it is liquid of love. I thank all the learned panelists for their valuable inputs on various breast issues. It was your dedication, diligence, and devotion that destiny brought us together for such a wonderful panel discussion. ज्ञान समुद्र के मंथन से हम रत्नों की सौगात लेकर जा रहे हैं. ज्ञान के प्रकाश से अज्ञानता के तम को हम सब मिलकर मिटा रहे हैं. It is the presence and participation and audacity of the august audience which attributes to the success of any webinar. I thank with all gratitude all the participants participating in this webinar. Last but not the least, but in fact, the most valuable is the contribution of the technical support provided by Walter Bushnell and team. Thank you all for your wonderful presence and a magnificent evening spent with you all together. Thank you so much.
Thank you, Dr. Seema, for a wonderful moderation and vote of thanks. And thanks to our technical support and academic partner, Walter Bushner, all worked throughout very nicely, full team. Dr. Vishal was not there, but Ranjit was there, Yogen was there, Ansh is here still, and whole of the team that worked day and night with me to prepare the flyer and have the full support. Thank you so much. Thank you so much. Dr. Meera Agnihotri ma'am is still there. I think, thank you so much, ma'am, for your blessings.
So thank you so much, doctors, for the session. The entire session was highly informative and covered almost every facet of the topic. I, Ansh Ravi, on behalf of the entire Walter Bushnell family, thank you for your support. So thank you once again and have a lovely evening. Thank you. Thank you.
Okay, bye-bye. Bye, Dr. Nikhat. It was wonderful with interacting with you. Although we interacted first time, but this was a wonderful that experience which I had. You are a lovely person and knowledgeable, very knowledgeable. Thank you so much. You are muted. You are muted. Okay, bye. Now Soumitra is also there. Thank you so much, Soumitra. Okay, bye-bye.
Thank you. Thank you. Bye-bye. Yeah.
Okay.